2, 1.
Hello, my name is Marco Diosanio. I'm professor of cardiac surgery at the Polytechnic University of Marche and chief of the cardiac surgery department at the Lancisi Cardiovascular Center in Ancona, in Italy. And I really would like to give you my warmest welcome to the episode 2 of our minimal invasive and transcatheter cardiac surgery Ancona Live virtual course. As you may know, I strongly believe that the adoption of minimal invasive and transcatheter techniques is a must for cardiac surgery today. So based on this notion, our Ancona Live virtual course has been ideated to support those cardiac surgeons who want to start with or reinforce their minimal invasive and transcatheter cardiac surgery program. So it is under this perspective that today and tomorrow we will make a focus on minimal invasive and transcatheter techniques to treat patients with the coronary artery disease and aortic aneurysm, and tomorrow with mitral valve disease. Let me express my gratitude to our faculty, a faculty that is made of true stars, of leaders in the field that with an enthusiasm going far beyond my best expectation have accepted to contribute to the realization of this meeting. They will give visionary lectures on the future of our specialty. I thought, and I think it is important to know how these leaders imagine our future, our tomorrow, to get prepared and to know today what we have to focus on, where we should preferably invest our energies when we are every day at work in our hospital. In addition, our faculty members will share their minimal invasive and transcatheter techniques in details and in a step-by-step fashion with videos. I really love that. I had the opportunity to preview some of the presentation. I can guarantee the value of this presentation is just amazing. I'd like to thank CTSNet, a perfect partner for our global meeting, and Maddalena Brachetti and Noema Congressi for their hard work with the organization of the meeting and for the patience they have shown with me over the last 2 days in particular. I'd like to thank the sponsor for believing in our online education project. This was something quite innovative last year, and I'm greatly appreciating their trust this year as well. And I would like to thank you, the audience. I really wish this meeting will be your meeting. That is demonstrated by the fact that this year we have accepted a video abstract from outside the faculty. We have a chat. Last year, the chat was just hot. I really hope this year will be the same. So please make your comments live, make questions to the faculty. And last, we will have ballots to know what is your favorite approach, to know your opinion on main topics, and see if and how your faculty will be able to influence your beliefs and probably tomorrow your practices. Special greetings to Indian Association of Cardiothoracic Surgery. Thank you for your friendship. I know they're streaming our Congress for their website. And last, before I go, I'd like to say that it will be possible to see and watch the recordings of this meeting on CTSNet platform, but also from this website. Actually, we are streaming from the website of our research center for minimal invasive and transcatheter cardiac surgery. So whenever you want, at the end of the meeting, maybe you can take 5 minutes to surf a little bit around and see our surgical, scientific, and educational activities in the field of our Congress. So let me tell you, I'm very excited to give the kickoff to the episode 2 of our Ancona Live virtual course. And for that, I would like to invite the chairman of the coronary session to join me on this virtual stage. They are two friends. They are two young, smart, superb surgeons in the field of minimal invasive coronary surgery. We have Gianluca Torregrossa from Chicago. There are some rumors he's moving. Probably he can tell us something more if he likes. And then we have Wouter Osterling from Leuven, Belgium. So, dear friends, I leave you the stage. But before doing that, I'd like to wish the audience to learn as much as possible, to find, if possible, the right motivation to make progress tomorrow, and enjoy the show, of course. Thank you so much. See you later. Please, Wouter and Gianluca, you take the ball and proceed with the meeting. Thank you.
Thank you, Marco. Hi, Wouter, and
hi, Gianluca.
Thanks, everyone.
What a great way to meet again, and what a strange year it has been for everybody. Last year was very different than planned initially, but what good to get together again. and to exchange experience, to exchange ideas, with such a great program planned by Marco.
This is a great opportunity, and we are definitely delighted to see a room and space for minimal invasive coronary artery bypass grafting. That is the niche of the passion of Wouter and mine. And we are here together with an incredible team of faculty that will give a perspective of this field. I think this is the time to launch immediately, to respect the time, the first ballot. We will ask you to vote for the first ballot right now. And the first question is, what do you think a minimal invasive CABG program would add value to your own institution? This is the question. You can use your right bottom corner click to choose among the 3 different options.
And it is very important for us to learn and to see what you're thinking, what is inside your head, and to know and to see how this evolves in the future. It's very important, I think.
Absolutely, and it will be even very interesting to compare with after the presentation will be done. The ballot is closed.
The first one is closed. First one is closed, and that brings us to the second one. And please vote for your favorite approach for Lima harvesting. And also here you can again vote by clicking on the right bottom of your screen, and you should be able to vote here right away.
We will compare these questions with before and after the presentation of our faculty, and we will see the impact that this meeting have in your perception about starting a minimal invasive coronary bypass grafting program.
And what a great way to add some extra science, Gianluca, extra science inside the presentations. The ballots are closed again. It will be very interesting to see at the end what is happening, to have all these presentations from everybody, and to see what evolves in our public.
Exactly, and I will immediately start to respect the time with the first of our faculty, and it's an incredible pleasure to introduce Dr. Mario Gaudino. He doesn't need any presentation. He is from Weill Cornell Medicine in New York City, and he will speak about the coronary surgery in 2030. Mario.
So thanks very much, Gianluca, and thanks Marco and the organizing committee for having me to this really cutting edge meeting. You guys are moving the field forward, and it is a true privilege to be here. I'm sorry we had some issue with the slide, but I think now we should be all set. So my task is to discuss coronary surgery in 2030. And well, I must say, when I got the invitation from Marco, my first reaction was like, well, are we sure there will be coronary surgery in 10 years from now or 8 years from now? And clearly, I was thinking of the ischemia trial. Ischemia has really a game changer, in my opinion, the most important trial in the cardiovascular field in the last 10 years. And we all know that in ischemia, a strategy of initial revascularization was not superior to a strategy of initial medical therapy in a patient with ischemia and non-left main coronary artery disease, in terms not only of death, but also of major cardiovascular events. And this is something that is not only ischemia. This is a meta-analysis looking at all the trials that have compared revascularization, mostly by PCI, and the medical therapy for patients with stable ischemic heart disease. And no difference was found, not only in terms of death, but also in terms of overall myocardial infarction. There was a reduction in spontaneous myocardial infarction, those myocardial infarctions that occurred during the follow-up, but there was also an increase of periprocedural myocardial infarction with revascularization. So the overall effect was neutral. Where instead an effect is seen, not only in ischemia, is when it comes to symptoms and relief from angina, and the effect is stronger in patients who are highly symptomatic at baseline. So there is no doubt that ischemia is, after ischemia, we should ask ourselves, are we revascularizing too much? And is revascularization associated with survival or prognostic benefit in the midterm, like we have been thinking for many years? Well, a very important consideration that must be done is that in ischemia, and in the overwhelming majority of the study that have compared revascularization with medical therapy for stable ischemic heart disease, the majority of the revascularization procedure was performed by PCI. Now, there is an intrinsic difference between CABG and PCI in terms of the effect of the coronary circulation. PCI treat only the flow limiting lesion, so relief ischemia, but has not any other effect on the coronary circulation. CABG instead provide a surgical collateral that not only treat ischemia, but also protect against the progression of lesion that you can see, as you can see in this picture, were not flow limiting at the time of the initial operation. So CABG add to the treatment of ischemia a protection against the future development of atherosclerosis. And this is particularly important because I think it is worth reminding that in patients with coronary artery disease, it is the number of non-obstructive stenosis that are really the driver of the prognosis. The number of non-obstructive stenosis is clearly higher than the number of flow limiting stenosis, and in the end it is the atherosclerotic burden, not the number of flow limiting lesions, that determine prognosis. Most of the spontaneous myocardial infarction that occur after intervention in patients with coronary artery disease are not related to flow limiting stenosis, but to stenosis that were not flow limiting at the time of the initial operation. And in fact, it has been shown that in revascularization trial, a benefit in survival or even in a reduction in cardiac death has been found only when revascularization has also been associated with a statistically significant reduction in the number of spontaneous myocardial infarction. And we have recently published on GTCVS this meta-analysis looking at the trial that compared PCI and CABG. And we found that a survival benefit for surgery was seen only in those trials where surgery was also associated with a statistically significant reduction of myocardial infarction because of this protective effect that I keep mentioning. So the two interventions are clearly different, and the result of ischemia do not necessarily apply to bypass surgery, but more closely apply to PCI. And we know, in fact, that in the long term, the result of the two interventions are different, and over the years, there is a survival benefit for CABG compared to percutaneous intervention. So I think after thinking about it, I felt a little bit reassured. It seems I will be in business 10 years from now. And then the next obvious question that I've been asked for many years is what kind of conduit will the coronary surgeon will be using in 2030? And I know that most of you now are thinking, oh, okay, I know the story. Use the arterial graft. Arterial graft are the best. Just go with them. Well, I think I will challenge some of the common concepts today. We have just published a meta-analysis of all the randomized trial that compared the different conduit used in bypass surgery on JAHA 14 trial, more than 3,600 grafts, mean follow-up of 5.1 years. And first of all, what we found is that there are only two conduits for whom we can say with some degree of certainty that the midterm patency rate is better than that of the traditional harvested saphenous vein. One is the radial artery, but the other is not an arterial conduit. It's the no-touch saphenous vein. There is not enough evidence to say that the patency rate of the right internal thoracic artery of the gastroepiploic artery at midterm follow-up is higher than that of saphenous vein. And if you look at the result a little bit more in details, well, you will see that for the comparison between the radial artery and the traditional reverse saphenous vein, there is a clear effect in favor of the radial artery. This is not true for the right internal thoracic artery. It is true for the no-touch saphenous vein. And when we compare the radial artery versus the right internal thoracic artery, well, there is a signal in favor of the radial artery, but there has been only 3 trials and slightly more than 400 patients. So the evidence is weak. So the only thing we know for sure in terms of arterial conduits is that the radial artery has a better patency rate than the saphenous vein. For the right internal thoracic artery, well, we are not sure. Let's look at the evidence in terms of clinical outcome. We know there is a large observational evidence that suggests that patients who receive multiple arterial conduits, in this case the radial artery, have a better long-term survival compared to patients who receive the mammary and vein. The same is true for the bilateral internal thoracic artery. But look at this meta-analysis we published a few years ago. We look at the difference in survival between patients who receive bilateral versus single internal thoracic artery, not only at the end of the follow-up, but also at 1 year follow-up. And the reason why we picked 1 year follow-up is that we know that the patency rate of the right internal thoracic artery and the saphenous vein is the same at 1 year follow-up. So any difference in survival between patient groups at 1 year cannot be due to a treatment effect of the intervention. And we found that at 1 year, the difference between groups was exactly the same at the end of the follow-up, testifying how there is a strong treatment allocation bias. Comparing patients who receive different intervention in observational study is intrinsically wrong. And this is because we as a surgeon select the intervention based on the patient we have in front of us. And we utilize multiple arterial grafting in those patients that we believe have a longer life expectancy. So in the end, we are comparing different patients, and the difference that we see, it's unlikely due to the treatment effect. And this is an example of the treatment allocation bias. This is a paper from the Cleveland Clinic for a different topic. Cleveland Clinic, you know, is the mecca for the use of multiple arterial grafting. If you read the first line of the method section and make some math, they are using the bilateral internal thoracic artery configuration in about 150 patients per year. Now, they do not give the denominator, but I'm sure they do more than 150 CABG per year. There is a very strong treatment allocation bias that we cannot ignore. I just think we cannot derive any information about treatment effect in observational studies, from observational studies in surgery. So what about the randomized evidence? Well, we all know the ART trial. 36% of the patients received a different intervention because of the high crossover rate from bilateral to single ITA and the frequent use of the radial artery in both groups. However, large trial, more than 3,000 patients, 10 years follow-up, no difference in survival and event-free survival between the two groups. It is true that in an observational post-hoc analysis where patients were stratified based on the number of arterial grafts received, there was a clear difference in favor of patients who received multiple arterial grafting. But again, this is an observational study within an RCT, with all the treatment allocation bias that I have just discussed. On the other hand, I think it's important to highlight how in the ITT analysis, the use of the radial artery was not a treatment effect modifier. And in the true per protocol analysis, where basically patients are assigned based on the intervention they receive, and so the crossover effect is neutralized, well, the trial was neutral. So I am not sure that the justification that are generally used to explain why art was neutral are truth. It is possible that there was simply no treatment effect. For the radial artery, things are different. So think about it. We know that the radial artery has a better patency rate. And when we look at the randomized evidence, the results for the radial artery are much more solid than that of the right internal thoracic artery. We showed that at the 5 year, the use of the radial artery in a pooled meta-analysis of 6 RCT was associated with a statistically significant reduction in the risk of MACE and graft failure. Looking at the individual component, we found no difference in survival, but a statistically significant reduction in repeat revascularization and postoperative spontaneous MI. However, the 5-year analysis was a major limitation, was mostly underpowered for the individual component of the composite outcome, and the revascularization rate that was driving the composite outcome was inflated due to the use of per protocol angiography. So we have extended the follow-up to 10 years in 2020, and we published the result in Journal of American Medical Association. We confirmed the benefit for the extended MACE outcome, including repeat revascularization, but what is most important to me is that we also found a statistically significant reduction in the risk of a composite of death and myocardial infarction. So taking repeat revascularization out of the equation and focusing only on heart clinical outcome. We also found a difference in survival in favor of the radial artery. However, that was a post-hoc analysis. Also note how the curves are almost superimposed for the first 5 years and then start diverging. So if there is a benefit for multiple arterial grafting, it's a benefit that you see late during the follow-up. At subgroup analysis, something I like to point out, women benefit the most from the use of the radial artery. However, again, it is not a postdoc, but it is a meta-analysis of RCT, so it is not as solid as a large RCT. So this is why we designed the Roma trial. It is the largest, Roma is the largest CABG trial designed so far. It is being run in more than 70 sites all around the world. There are a lot of sites from Italy and from Europe. We are at the moment at around 65% of the enrollment. The final sample size is 4,300 patients. We are around 2,700. We hope to provide the result for the main analysis at the end of 2025. And with this slide, I thank again the organizing committee for the privilege of being part of this important meeting. Thank you.
Thank you so much, Mario. That was an incredible value presentation. Happy to know we still have a job looking forward, and we will definitely at the end of our presentation series debate some of the very cool topic you brought up, particularly this value of the Rita versus the radial. It is now my pleasure to introduce my co-chairman of the session, an incredibly bright surgeon, Dr. Wouter Husterling from the Department of Cardiac Surgery in Leuven, and that will speak about why and how to build a hybrid program for coronary artery disease. Wouter, please.
Thank you so much, Gianluca. And indeed, the previous speaker, Mario, there is a lot to do about grafts and what and how to use it. So let's continue in this discussion. I'm a cardiac surgeon from Leuven. I'm also a proctor for Medtronic, Orsi, and Intuitive, and I'm a big fan of coronary surgery. These are my disclosures. Why should we talk about hybrids? Well, certainly we have more complex coronary artery disease. We have to face patients with a lot of more comorbidities and an increasing amount of frailty. And this brings us to the fact that the landscape for revascularization is actually changing. We need to reduce our level of invasiveness and certainly need to reduce further our complication rates. And early recovery after surgery, it has become a key player in our approach as cardiac surgeons. And full revascularization does not, per definition, mean full sternotomy. These are things to keep in mind. And in a hybrid setting, we actually are going to revascularize the LAD and combine it with the PCI to the remaining vessel or territories in multi-vessel coronary artery disease. This can be simultaneously or can be a staged procedure. So the 10 reasons for me to go for a hybrid program is that more patients in the end will finally receive the best treatment that we know, which is in Lima to the LAD. Patients we actually did not talk about anymore, that were just stented without our knowledge, are now discussed again at the heart team meetings. And this is a good thing. This will improve quality, improve outcome, and improve treatment for patients. Secondly, the hybrid approach is certainly less invasive. It takes away the severe wound problems that we can see in the very obese and fragile patients. And actually also by the cardiologist, I see every day that midcap is seen as an intermediary procedure, intermediary invasive between CABG and PCI, also by the patients. And it has the same quality targets as in open surgery. That is not different. In early recovery after surgery, it also takes an important place. We see that patients go home a few days sooner, and especially the first 3 months and the first 6 weeks, we see that the return to full activity is much bigger after midcap procedure, even if in a hybrid setting the PCI procedure is included. Hybrid approaches can have excellent outcomes. The scores that we see are better than predicted by the Euro 2 score and have a very low complication rate. You don't have to fear anymore the depth or bleeding risks that can be associated with the dual antiplatelet treatment. So we see in our patients that even the ones that are on Brilic and Azaf and Cardiasprin, they don't bleed more. They are just doing the same way, and that's mainly due to the fact of the gentle and very accurate dissection with the procedure. Some extra data, a meta-analysis that we performed recently show that there are less early strokes in beating heart procedures and less reintervention rates at the long run. So less long-term reintervention rates than PCI. So the hybrid clearly improves the strategy of the PCI and lowers the risks afterwards for the patient. And then eighth, we have a culprit lesion treatment. This is also very important. It takes away the pressure that a CABG is a one-hit event. And if you do a CABG, you need to do everything, even if lesions are non-significant. So this is an old strategy that we should lose as soon as possible. And having the midcap as a procedure in your arsenal, it enables you to discuss this with your cardiologists, and they accept it. And we evolve more and more. I think the coronary surgeon of 2030 will certainly be a team player. We have to know that together everybody achieves more, and especially the patients. And the hybrid discussion actually set the correct tone towards a true team approach. And then last but not least, cardiac surgery again can take fully part of the strategy making. We are no longer the last and worst option to pick for the patient or the cardiologist. No, we offer a range of options, and we can clearly discuss this together with the cardiologist, at what time point could be the best option for a certain patient. We created our own flowchart here to promote and to reinforce the hybrid strategy and the minimally invasive strategies. But this is not only midcap. This is also midcap BIMA approaches. This is also CTO PCI. And we can make the best combinations for single, double, or triple vessel disease, but also still have CABG and OPCAP as a respected procedure available. So this is why I think why you should build your hybrid program and how you should build it. There are many options, and many speakers today will give their valuable input of what you can do. We have chosen to take the robotic approach because we thought it had a very small learning curve and a very delicate, accurate, precise way of dissecting memory arteries. We wanted to find the solution that enabled us to go off pump, to stay off pump, and still have excellent results and even further improve the results. Because we strongly believe if you want to perform better than in the past, we need to use the best and most accurate tools that are available. And also training is key. So start to do your procedures in a team approach. Combine it with older colleagues that are there or colleagues that have experience in other type of procedures that are related, and always interact with your cardiologist. Help them out in the tough cases. Some chronic occlusions where they are disappointed, if they have any dissections or they have some disappointments in their approaches through PCI, help them out, even if it's an open OPCAP or cabbage procedure, but this reinforces your team approaches and recognize their values and your outcome parameters as well. Do not underestimate what we call small problems like some pleural effusions and such. They consider it often as big problems, and you need to deal with them and have an excellent patency rate, and also make sure that you create outputs and publish your patency rate and how it evolves in the future. Trying to move to the next. Yeah. So how to build? Certainly try to have some experience in OPCAP. Slowly then move forward to mid-cap LED procedures before you start to move to multi-vessel mid-cap or multi-vessel multi-arterial beating heart procedures. But I think OPCAP is the way to start, and then start easy with a simple LED, an ideal chest. That's the way to grow. And there are many people around that are able to help you. The goal of everybody is to improve outcome and avoid complications. So please do not touch the aorta. The beating heart procedure can be a really safe procedure in well-controlled conditions, but make sure you have some off-pump procedure so that the first shunt that you are going to place is not in a mini thoracotomy setting. And closely monitor and follow your patients, and make sure you create your own CUSUM curves about your outcome and how complication rate evolves after your procedures. In case of robotically assisted procedures, do not fear the use of dual antiplatelet settings. And that is also something that is classic in a hybrid approach. If a patient is stented for non-STEMI, for instance, and he's on Brilic, do not fear to operate your patient on Brilic. We have seen that the blood losses are minimal in a RACA procedure. So include all patients, PCIs for STEMIs, non-STEMIs, and all elective strategies. All these patients deserve a good Lima to the LAD. Make your own flowchart. Every hospital, every team is different, so you have to make your own flowchart in accordance with your minimally invasive options that you have, and go through these options. They can evolve over time, and discuss endlessly with your cardiologist. Have a live meeting. Digital meetings are good, but live meetings, there are jokes to be made together with a cardiologist, and sitting together, it reinforces the team approach. Here we see that about 20-25% of our cases in the mid-cap are hybrid cases, and they are growing. The numbers are growing rapidly. And I'm ending here with a case which is a hybrid case where the right coronary artery ought to be stented, and where the diagonal and the LAD were significantly stenosed and needed actually a mid-cap procedure to the small or diagonal, which is occluded, and the end of the LAD. So you need quite a lot of length because it's a distal diagonal that needs to be bypassed. We put our patients always flat. We just put one arm underneath the buttock, and then we place our trocars, always doing this in a gentle way. We minimally apply some CO2 just to help the lung collapse after the bronchus blocker is placed. And then we sit next to the patient and start our surgery. We use a tweezer and a spatula. We take, of course, care of the phrenic nerve not to touch. I always mark the targets that I want to go to, and then I go for the mammary artery first, freeing up the whole course, making sure that I identify the complete anatomy of the mammary artery. Then I go below before at the end I take all the side branches down and go around it. We give heparin at the moment that we clip the mammary artery. We inspect the full length. We can instill some papaverine if we think it might be appropriate. And then we place a bulldog at the end of the thoracoscopic procedure just to make sure that the mammary artery is not lost in the chest and can be easily found through the mini thoracotomy that we make. We always place a wound protector. Sometimes we use a rib spreader, not always in a diagonal. Sometimes it can be easy, but the most important thing is to play with the pericardium and to lift the pericardium nicely so that the fat is out of the way and that your targets are really nicely into position. Always mark the best spot to land on my lima, and then I introduce the suction device through the lower trocar point so that it's completely out of the way. Most of the cases now, I actually pull the pericardium after already introducing the stabilizer, which makes it easier. This was a smaller diagonal. It was a 1.25 shunt. It was occluded, so you just place a shunt, and if you have the habit of doing upcap, you really rely on your shunting and not touching the wall anytime. I prefer also to place shunts in my mammary artery because it helps you not to touch the wall at all. You can just take the shunt, lift it up and down, and it's easy to connect it afterwards, even when it's brought down already to your target. We always use a blower mister, which I think is very useful in minimally invasive procedures, and there are many types available. Make sure that the tissue does not dry out. That is a risk, and make sure that the flow of the CO2 is low. Always check your flows, even if the targets are small. Always go for good flows, and in case of doubt, check your flows and PI. Do not hesitate to redo your anastomosis. The worst thing that can happen is that your anastomosis is not good, and you need a quality control at the time of the surgery. And then you end with your LAD, which is not too far away from the diagonal here. Bring in your shunt again, making your anastomosis in a semi-parachute way again, and then take out the shunt and finish up the last step of your anastomosis before you remove your stabilizing device. Also there, you need to check your flows. Sometimes the flows to the LED, you need to check them after you remove the stabilizer. And if you close the pericardium, watch out. I rather take some fat to put on the medial part of the pericardium, because if you take the pericardium and pull it very hard, it can create some tension on your graft, which you don't want. And we have the habit of closing the rib space slightly just to avoid a lung herniation after surgery, especially in COPD patients. And then that's it. The stent to the right was placed shortly after, and patient recovered very rapidly and well. So that was the video of our hybrid case. And I think that the future of cardiac surgery is through minimally invasive surgery. And many minimally invasive options, which will be shown here today, are available. Start small, start safe, and allow to grow in team together with your cardiologist and together with other surgeons that can help you grow. Get experience with a good backup plan, because there is support out there to help you to grow. I think that's the most important message I can give you today. So Gianluca, that brings us to the next speaker, Dr. Nambala, speaking about other techniques. I think he will be the person to talk to us about the direct view lima and rima harvesting. Dr. Nambala, thank you for joining, and we are looking forward to your experience in the harvesting of the mammary arteries.
Fantastic. First of all, I should congratulate Marco on a really good program that's been put together. And I also have to thank him for having me here. And chairpersons, a very good afternoon to you. It looks very interesting. Let's go on. I'm going to keep this very brief. This is going to be mostly technical. I think the previous two speakers have already elaborated on which conduit you would prefer. I think, I too would prefer the radial because it's easier to use as well. Also, my topic today is about Lima and Rima harvesting. So I'm Dr. Satiki Nambala. I'm a cardiac surgeon from Bangalore, Karnataka, India. That's the south of India. So going on to the next slide. Obviously, this is going to be a question that everybody is going to ask: why bilateral mammary arteries? The often stated drawback of a mixed CABG is the difficulty in ITI harvesting, which is actually not true. With a little bit of experience and a little bit of effort as well. There is some accumulating evidence in favor of total arterial revascularization. I know it's still not very, very clear, but I think using both mammary arteries, particularly in a young patient, does make a difference, especially in the long term. It also avoids manipulation of the aorta and thereby reduces stroke rates. And like I already mentioned, it's particularly beneficial for very young patients. I'm going to go on to the tools that you require for bilateral mammary harvesting, and the next slide will show you the actual tools. You basically require a retractor system. When I say a retractor system, I'm basically stressing on a rib retractor as well as a rib spreader system. Now, there are multiple companies that manufacture these today, but I generally prefer either the Medtronic one or the Felling one. And for routine use, I prefer the Felling one because it really gives you a good rib lift and the visualization is fantastic. You definitely require a single-shafted mammary grasper. There are multiple companies, again, manufacturing this. I prefer the one that's manufactured by Geister. You also require a single-shafted clip applicator. Again, multiple companies, but the Felling and the Geister ones are really long and effective as well. Now, when you come to the energy source for harvesting, I know most people are very comfortable with an electrocautery. That's good as well. But if you get comfortable with the harmonic scalpel, you will find that you have to use a lot fewer clips. The harmonic scalpel simply cuts and seals as well, and the smaller branches don't have to be taken care of. So which means that you can continuously harvest the mammary. Your harvesting time drastically falls down to less than 10 minutes for the LITA. And for the right internal mammary artery, it may take a little bit longer time. Also note that the harmonic scalpel has a longer handle, which will actually reach very well to the right side of the chest. So this picture basically shows you the various tools. You can see the harmonic scalpel on your extreme left, and you can see that that probe is really, really long. It's sickle-shaped. It cuts. We usually try to use the higher energy at 5, not at the 3 setting, because the thermal spread at 5 is supposed to be much lesser. We also notice that, you can simply cut across the branches. You don't have to wait like with the lower energy. You can also see the clip applicators there and the conventional cautery. And if you're using a conventional cautery, both Ethicon and multiple other companies manufacture long probes. They're still not long enough to reach the right. It may be a little more tricky because you have to really hold towards the extreme end of the cautery handle. But these, I think, are necessary. Now, the next picture shows you how we do it. We basically place the incision on the 5th intercostal space, about 2 to 3 inches, 1/3 medial, 2/3 lateral to the midclavicular line. And we tend to place it much lower down from the nipple, about 2 finger or 3 finger spaces below the nipple. Because I think the nipple area is very sensitive and it is preferable not to traumatize the area around the areola. Patients can really come back with a lot of sensitivity issues around that area. You also note in that picture on the right side top that this particular patient from whom this is recorded has a pectus. And speaking of contraindications, this is a relative contraindication for bilateral mammary harvest, as your visualization is definitely obstructed in patients who have a pectus. But we still went ahead and did this. The pectus did not seem to be very bad, but when we did go in, our visibility was definitely affected. So if you have a pectus, it may be prudent to use a robot with the ports inserted from the opposite side, not from the left side, but from the right side. But it is still doable. Now, because this patient had a pectus, we prefer to use a xiphoid hook. You can see that on the left big picture. A xiphoid hook is also mounted onto the same retractor, and what you see is that the incision through which the xiphoid hook goes is also the incision for the introduction of the starfish. So through the same incision, you could also introduce the starfish when you're doing a multi-vessel cabbage, mixed cabbage. You can see the position of the surgeon as well. It may be a little cumbersome to do the right, and definitely if the surgeon has to do multiple cases in one day with both lima and rima harvesting, it can be tedious. So if you have a good assistant who can take down the rima for you, it definitely shortens your operating time. So the next one is a video. This is the mammary hook that we talked about, and you can see that the right internal mammary artery is already dissected partially. You can see the harmonic scalpel hook being used. I prefer to take it down skeletonized, and I think it comes out really well when you do it skeletonized. It also reduces the amount of paresthesia that patients have when bilateral mammaries are harvested. Now, you will also note that we actually tucked in a sponge on the right so that, you can keep the lung down and you really don't have to make it uncomfortable for the anesthesiologist. He can continue to ventilate with low tidal volumes. Both lungs can be ventilated. And you simply wet a sponge and push the lung down while you take down the mammary. You'll also see that the harmonic scalpel reaches very well. Now, because this patient had pectus, we did have difficulty visualizing it. You can see already that most of the mammary is already down, and you can cut the branches either with the harmonic scalpel, but if the branch is really big, I would prefer to use a scissor to cut between clips. It keeps the thermal spread, it prevents thermal spread and thermal injury to the mammary. And you see here that I'm also using a conventional cautery in between. It's not routinely required in all patients if you're using a harmonic scalpel, but with this particular patient, visualization was really difficult and probably the wrong choice to do a bilateral mammary. But this patient was only 40 years old, and we thought, using bilateral connection there. All right, it's back. So you can see that most of the right internal mammary artery has already been harvested, and the upper part can be a little more difficult. And one trick is to put on a stay suture on the pericardium or the extrapericardial fat and pull it towards the left, and it pushes the heart down and gives you a little more space to take that part of the mammary down. The vein can be divided if you want to go right up to the top. And similarly, if you want to do the bottom, you can actually put a xiphoid retractor to, pull on the soft tissue retractor. And I do recommend that all surgeons who are going to start this technique use a soft tissue retractor, because using a soft tissue retractor keeps all the fat out and makes visibility much, much better. I did record this with an endoscope, and the endoscope keeps fogging because the harmonic scalpel, as you can see, creates a lot of, steam as it cuts to the tissue. The rima was harvested with the conventional cautery. And you can see that in this particular patient, this is the last bit of that video from a different patient. And you see that, the visibility is pretty good and the whole rima can be harvested very, very well. I'm going on to the next slide here. And liter harvesting is actually very, very easy. And with the harmonic scalpel, should not take more than 6 to 8 minutes with experience. And like I said, if you use a harmonic scalpel, you really don't have to clip the small branches. And once your surgery is complete, we simply squirt some water and check, to make sure that there are no branches that are bleeding. And if we did find a larger branch, we would simply put a clip on subsequently. It's actually a little more cumbersome recording videos on a head camera when you're doing a mixed cabbage. But when you look through your loops, your visibility is exceptionally good, and the entire length of the mammary can be harvested right from the bifurcation below onto the top and beyond the first branch. And this patient also had some lung adhesions, and you can see the entire length of the mammary harvested there. there. So I'll go on to the next video. I think what's very important is that the length of the memory harvested, the right memory particularly, has to be approximately 6 inches if you plan to graft the PDA as well. So if it has to go as a Y graft from the LITA onto an OM and to a PDA, you require a minimum 6 inches. And you can see the video playing on the lower right corner, and you can actually see the RITA like that in a good chested patient. But if a patient has a pectus or is significantly obese or is small chested, the visibility may not be very good. And personally, if you did have a robot, taking down the RITA with a robot is actually much, much more easier compared to this kind of harvesting. Again, 2 more videos. You can see a good length of RITA harvested there, good size as well. And we simply prefer to put, do the LITA to LAD first and then construct the Y subsequently. We simply push the octopus further down wherever we want to stabilize on the, wherever we want to do the Y, and simply stabilize it with the octopus and then do it, which makes it a lot more fewer steps than trying to do it before doing the distal. And you can see the octopus on the right side. You can see the octopus going through there. You can also see the starfish, which has been introduced subxiphoid, and you can see the RITA reaching the PDA. Now, this has been our routine practice, either to use a right internal mammary or a radial artery for total arterial revascularization. I wouldn't say you would do this in the first few cases. Our experience now has been about 1,800 procedures so far, and using the radial has become much more routine than harvesting the right internal mammary artery. And if it's a young patient, like I said, I would prefer to use a robot and take down both vessels and then do a nice operation. Then you don't have to lift the ribs as much, and definitely patients do much better when robotically harvested. Like I said, I'm going to keep this brief. This is how this incision will heal post, about 2 weeks to 4 weeks post-surgery. It's extremely gratifying to see patients, with cosmesis as part of the surgical package. Patients are also extremely grateful. And like, the other speakers mentioned, cardiologists are also extremely happy with this kind of a outcome. So a few tips here. We generally harvest the rima first. If you did the lima first, then usually, endothoracic fascia and tissue tends to obstruct your view of the right internal mammary. Like I already mentioned, you use a stay switcher for traction placed on the far edge of the pericardium. It allows better exposure of the rima, particularly the top end. With experience, like I mentioned, you can harvest this really, really fast. It should take less than 10 minutes to harvest a lima, and maybe about double the time to harvest the RITA. Again, already mentioned, 6 inches is what you would expect to harvest if you want to do a triple vessel bypass sequential. Thank you very much. I think I'm done here.
Thank you, Dr. Nambala, for this great presentation, and congratulations with your perseverance. It is an honor for me to also introduce to you today Dr. Torre Grossa, who will speak to us today about robotic lima and rima harvesting. And he has become extremely experienced. I'm looking forward to what he has offered for us.
Thank you, Walter. Thank you, everyone, for the kind invitation today. I want to congratulate Dr. Nambala for the outstanding presentation he just gave us. I will show you a different approach to harvest the bilateral internal thoracic artery using a robotic platform. Before starting any type of techniques or training curve that require dedication, you should have a strong why. Why should I learn robotic bilateral internal thoracic artery? And the reasons, the answer to this why, are very straightforward to me. First is that robotic approach allows you to take bilateral internal thoracic artery on every patient, independently from their size. They can be obese, grand obese, independently from their HbA1c. You do not have any type of sternal wound complication. Because there's no rib spreading, you are not squeezing your eyes through a small keyhole and try to spread those ribs to increase your view. Patients have minimal postoperative pain. And by offering beta, you can increase the amount of patients that you can serve with a multi-arterial bypass grafting and with a hybrid approach, completing the revascularization. Finally, there is a superior opportunity to offer beta even in incomplete revascularization to patients rather than complete the revascularization with single internal thoracic artery and veins. As I do strongly believe the TCAB beta should be part of the armamentarium of the portfolio of the techniques that a dedicated coronary surgeon should have in his hands, not as a substitute to sternotomy CABG. Beta TCAB is not, in my view, a substitute to sternotomy bypass, not on pump, not off pump, but as an add-on to complete the portfolio, not to compete against the techniques that we use, but rather to serve patients that currently receive multi-vessel PCI. And here's some data from Cleveland Clinic and from Emory University about the importance of multi-arterial bypass even in the setting of non-complete revascularization. Giving beta to the best target of the left coronary system is a very important task, our daily activity as coronary surgeons. And when you address the rest of the coronary artery disease with stent, you can do what we call advanced hybrid revascularization, multi-vessels and advanced. Here, a video of the technique. These are my surgical notes that I took during the last 3 years, both at Mount Sinai Hospital with Dr. John Pascas, and during the last 2 years, working with Dr. Sam Balke at University of Chicago. We mark our 3 sites in the second, fifth, and second, fourth, and sixth intercostal space. We call for lungs down. We introduce a Varys needle. We insufflate with CO2, and we insert the first trocar. We insert 2 more trocars, 8 millimeter for the right and left robotic arm. This is the distribution, and please note how the right arm is slightly low to avoid conflict with the shoulder. We then advance the robot. The robot should not come perpendicular to the patient, but slightly with a 30 degrees angle. That's very important to avoid, again, conflict. We sit at the console, and the third things we should do is to create space for ourselves. So don't harvest immediately the vessel, but rather open the pericardium posteriorly to the phrenic nerve, reverse towards the feet, the anterior mediastinal fat, and then open the pericardium and observe your distal target. In this case, an LAD and an OM posteriorly to the phrenic. Then you identify a triangle defined by the phrenic nerve, the thoracic wall, and the great vessels. And you open in the left corner of that triangle the right pleura. So again, we are opening the right pleura still with the same 3 trocars that we will use from the left side of the chest to harvest only a lima to LAD. So Rita and Lita are harvested from the same site, from the same trocars. Here you see the superior view that the robotic offer. We enter in what we call three-quarter anterior. Is the fascia just in front of the vessels of the right internal thoracic artery. Look the precision. You are not rib spreading. The patient will not have pain after or minimal pain after the surgery. And you have a very fine and precise view of your vessel. Here we are taking and opening the fascia. We are managing the collaterals with 2 clips and a cut, or with bipolar force for the smaller collaterals. We then completely separate the Rita and harvest all the way down to the bifurcation. We then go for the Lita. As you see, we have not changed the robot. We have not changed position of the patients. The patients and the trocar site are still the same. Look at these two comparisons. This is me in 2018 when I started my robotic, and in 2020. Look how when I started, I was petting the Lita, like you are petting an animal, a cat or a dog, long strokes. Then I learned recently to do a more very precise and fine, faster type of movement, similar to those that you use when in a sternotomy, I use a harmonic scalpel. We then go towards the feet of the patient and we insert the subcostal fourth trocar that will host the end of wrist stabilizer. Here the end of wrist stabilizer, and then we insert in the second intercostal space the fifth and last trocar that will be the trocar for the working port, for which we will insert the sutures and the bulldog. The stabilizer is an essential tool to remove and to harvest the first 5 centimeters of the right internal thoracic artery. As you have seen, we use this stabilizer to pull down the anterior mediastinal fat, and then we can expose the proximal portion of the Rita. And we can arrive up to the first intercostal branch, all the way to the first intercostal branch, and we have a beautiful Rita that is all the way harvest. We then give some heparin, generally 5,000 units. We put a bulldog, we put a clip distal, we open the vessel, and eyes have inserted endoluminal papaverine or myrrinon when I was at Mount Sinai, but always prep my graft, even when I'm on a sternotomy. This is the technique that Dr. Balke used in Chicago with this spinal catheter that is inserted inside the vessel. And then we release the bulldog, and you will see the column of blood retrofilling your spinal catheter. At the table side, your table side assistant started to flash some papaverine inside the vessel itself. And then we gently dilate the vessel by very quickly closing the bulldog against some of papaverine. That will further enhance and optimizing the size of your vessel. We then remove the catheter, close the distal Rita, and you see a beautiful Rita after the bifurcation. And we do the same process for the Lita. In this case, the vessel, the catheter is already inserted, and we are already providing papaverine intraluminal. You see how you can see in a beautiful way. More than in a direct view, you have perfect and precise view. Again, we are using only 3 trocars in the left chest and 1 subcostal trocar for the end of wrist stabilizer. This is an essential tool. And these are the 2 internal thoracic artery ready to be deployed. In Chicago, using the end of wrist stabilizer, you can deploy them in a TCAB approach, or you can do a small thoracotomy and deploy the 2 vessels. So in conclusion, I want to thank everyone for having me here. There is a huge role of minimal invasive coronary bypass grafting, and the robot is the best option that we have for it. Thank you.
Thank you, Gianluca. It's wonderful to see those images and the precision that you can perform with the robot. So congratulations.
Thank you so much, Wouter. Thank you so much. I will say that we want to go ahead and present our next speaker, Dr. Cefarelli from University of Marche in Ancona, who will speak about a very interesting topic that is endoscopic saphenous vein graft harvesting. Please, Mariano.
Yeah. Dear Chairman, dear colleagues, I have no financial disclosure. So, despite evidence favoring the use of multiple arterial conduits for coronary artery bypass grafting, the great saphenous vein remains the most commonly used conduit worldwide because of its ready availability and easy to use. Several techniques have been described to harvest saphenous graft, so the traditional open technique, the no-touch technique, the bridging technique, But recently, so the endoscopy technique has gained a lot of interest. So in particular, many studies, as well as the latest European guidelines on myocardial revascularization, have reported that endoscopic vein graft harvesting should be considered to reduce the incidence of wound complications, postoperative pain, and length in hospital stays. But what about durability? So in 2009, an analysis conducted on 3,000 patients using database from Prevent for trials raised the concern that compared with conventional harvesting, endoscopic vein harvesting was associated with a higher rate of death, myocardial infarction, or need of revascularization. However, it was a not randomized study, and it was conducted by non-expert endoscopic vein harvester. In the recent randomized endovein graft perspective, the regroup trial, where only expert endoscopic harvesters were allowed to perform the procedure, there was no significant difference in terms of major adverse cardiovascular events occurrence among patients who underwent endoscopic vein harvesting compared with those who underwent conventional harvesting for CABG over a median follow-up of about 5 years. So with this video, I would like to share our experience with the two endoscopy techniques. So using two widely used devices, the VasuView system from Maquet, a closed tunnel system, and the VirtuoSAF system from Terumo, an open tunnel system. So in both systems, the selected leg is positioned so that a roughly 90-degree angle is formed between the thigh and the leg. A small skin incision is made on the medial face of the leg. The vein is dissected from the surrounding tissue and it's gently hooked with a silicone sling. So in the closed tunnel system, the HS site is occluded with a trocar port balloon that is introduced for about 3-4 centimeters and inflated up to 25 cc of air. So in this case, we have a steady CO2 pressure into the tunnel, which guarantees an optimal gratis vein visualization. And after dissection and side branch isolation, the endoscope is inserted into the VasuView harvesting cannula that is then slide into the tunnel over the superior face of the vein, of course taking care to avoid the side branch. And the syringe is then extended to the target vessels. The branch is then secured and is transected by closing the jaws and pulling back on the activation toggle until some resistance is made. So as you can see, this is a very safety system that does not produce hurt or shorten branch. On the other hand, for the CO2 open system, it is not necessary to use a trocar port balloon, and CO2 is delivered directly from the tip of the device. So in some studies has been described a reduction risk of CO2 absorption and embolism. And so as you can see, the side branches are dissected and prepared. The dissector is then pulled out and the endoscope and CO2 are connected to the harvester. So the device is then advanced through the tunnel until it reaches the proximal hand. So the B-lock is then opened in order to hook and protect the vessel. And pulling back on the harvester, is it possible to feel some resistance due to the presence of a side branch. So as you can see, is it possible to use the device with only one hand. And the collateral is then gripped and cauterized with cautery operating using the foot switch. The graft preparation is the same for both systems. The proximal hand of the vein is pulled out through the hole, is tied and cut, and then the vein is hooked and pulled out through the distal incision and cut distally, so under direct vision. All branches are then tied with 4 thick ties, and the graft is then flushed and stored in a saline solution. So in our experience in the last 4 years, we took about 400 endoscopic saphenous vein. and with a rate of saphenous wound complications higher in the open group, despite a worse population in terms of comorbidities such as diabetes and peripheral vascular disease. So in conclusion, while there are actually no data showing differences in terms of postoperative myocardial infarction, vein graft stenosis, need of new revascularization, and 30-day mortality between conventional and endoscopic vein harvesting, there are no doubt that this technology may reduce wound complications, improve quality of life, and respond to our patient requests. Of course, further studies need to be conducted focusing on vein graft patency. Thank you for your attention.
Excellent, Mariano. Thank you so much for your great presentation. It's my pleasure and honor to introduce one of the leader in minimal invasive direct coronary artery bypass grafting, Dr. Piroz Daviervala from the Leipzig Heart Center in Germany. He will speak about direct vision multi-vessel coronary artery bypass grafting. Piroz, please.
Thanks a lot, Gianluca. I hope you can hear me. I'd like to present on direct vision multi-vessel cabbage. My talk is pretty much a sort of combination of all the talks presented so far. And I just wanted to let you all know that I've moved from Leipzig to Toronto just about 2 weeks back as the director of minimally invasive cardiac surgery. Disclosures. So the major advance in coronary bypass surgery, apart from the use of multiple arterial grafting, has been the approach that we use for this operation. We've moved from the sternotomy approach on the left to the more minimally invasive approach, a left-sided small thoracotomy. First started approximately in the mid for a single vessel bypass, and then it moved on to multi-vessel cabbage. Now, the obvious advantages of this approach are that you avoid a sternotomy and all sternotomy-related complications. It has reduced infection rates. There's no post-operative physical restriction. Therefore, it's early recovery and improved physical activity and independence, which are very important individuals who want to get back to work. Also in old individuals who are living alone and want to be independent as soon as possible. It benefit, it also gives good cost message. So this is not a new operation. It's been around for the past 15 years, and it's thanks to Joe McGinn and Mark Ruel, who pioneered forming multi-vessel minimally invasive cabbage, and they presented their work in circulation in 450 patients, which showed the excellent outcomes for both double vessel as well as triple vessel bypass surgery. And they also showed that this operation was efficacious by performing a 6-month angiographic patency study, which showed that 100% of the LETAs were patent and about 92% of the vein grafts were patent. The lower patency of the vein grafts was attributed to the learning curve of the surgeons, but also in a way it could also be of vein grafts, which show a higher attrition rate even at 1 year as compared to arterial grafts. So this has discussed previously by Mario very efficiently, that more so for the radial artery, but I am more in favor of the beta, and this paper from David Taggart in Circulation in 2014, which is a meta-analysis of patients undergoing bilateral ITAs versus single ITAs, showed that the benefit of the bilateral ITAs was consistent not only at 10 years, but it seemed to continue even in the second decade after surgery. Then obviously he conducted the ARCH trial, which was one of the biggest trials in coronary surgery, and has already been said that it did not show any difference at 10 years between patients undergoing single or bilateral ITA grafting. However, when they looked at the as treated analysis, which is obviously a post hoc analysis, multiple arterial grafting showed the better survival than single arterial grafts. But the main highlight of this paper, what I took, is that the problem with bilateral ITA grafting is a sternal wound complication. And this was also highlighted in this trial, that sternal wound complications were twice as high and reconstruction rates were thrice as high in patients undergoing bilateral ITAs as compared to single ITA and veins, or radials for that matter, in this paper. So what we thought, that if we can completely avoid the sternotomy, the use of bilateral ITAs will not have any effect on sternal complications. So basically, you kill the problem completely. So we started developing this operation way back in 2015, and this is just a short clip of the operation. We do a small thoracotomy in the fourth or the fifth intercostal space, which is an incision, and we use a retractor which elevates the thorax. And I usually take the mammary down with a cautery, with a clip and cut technique, as opposed to Satyaki. And here you can see that the entire length, right from the bifurcation right up to the subclavian vein, is can be harvested. So just as Satyaki also showed, we previously used a lot of this elevating the lower part of the sternum by using a subxiphoid retractor. We do not use it very often anymore. I'll show you in the next slide. So once the lita is harvested, we move to the right, open the pleura, and here you can see the right internal thoracic artery being harvested in the same fashion, clip and cut technique. And you can see there that the entire length can be harvested if required. So I performed the Y anastomosis first. So I used the octopus as a platform, as you can see here, which and fixed the mammary to it, the left mammary, and then I performed the Y anastomosis. And here you can see the Y anastomosis can be performed under very stable conditions. The next step is to perform the lita to LAD, which is similar to any mid-cap approach. And we always, of course, perform transit time flowmetry on every graft. The next step, we move on to the lateral wall vessels. Here you can see a high OM, which is, we perform a sequential anastomosis between the reta and the high OM. And then once again, perform transit time flowmetry. So we use the armless starfish. We don't use the usual concoction from Medtronic. And with this, it is very, it gives us a great versatility in performing the operation. And then either a sequential or an end-to-side anastomosis, depending upon the number of bypass grafts that you're going to perform, is performed. And then, of course, once the anastomosis is done with, we usually do flowmetry and then close the chest. So it's about a 6 to 7 centimeter. So it was 8 centimeter at that time. We've come down to about 6 to 7 centimeters now. And the wound looks like, sorry. So this is, sorry. So this is something that we use now. We use these retraction sutures often, which is on the right side of the pericardium, and pull through a small puncture wound in on the left, as you will see here. And once you pull these sutures and keep them under tension, the space in the thorax tremendously increases to facilitate the takedown of the right mammary artery. So here we pull them out. And you can see here how the space in the thorax increases once we have pulled the sutures towards the left. So there are different ways in which you can use the bilateral. You can also use the bilateral ITAs in situ. On the left, you can see, I don't know why the video is not running, but On the left, you see the RITA to the LAD, and on the right, you see the LITA to the OM. That is, it can be performed in this fashion, or you can also, also you can use the LITA to the LAD and the RITA to the high obtuse marginal or an intermediate vessel. As you can see here in the magnified view, this is the RITA going around the left atrial appendage to the obtuse marginal, and this is the final incision or the scar that you see, and of course there's no risk of sternal wound infection. So the best patients for at least starting off your program to operate on males with a body mass index less than 30 and with a cardiothoracic ratio less than 50%. And a left ventricular end diastolic diameter less than 50. These are ideal patients to operate upfront. Lung function should be relatively normal due to on single lung ventilation during the operation, and avoid a RITA. As Satyaki mentioned, that pectus excavator makes it really very difficult to harvest the RITA. And also in patients who have received radiation, sometimes it's really stuck to the chest wall and is difficult to take it down. And of course, choose patients with good coronary targets, so avoid intramyocardial vessels and heavily calcified vessels. So we presented our initial results in JTCVS last year, where we included 88 patients from patient 1 to patient 88, and assessed 209 distal anastomoses. Most of the patients received LAD and circumgrafts, percent received right coronary grafts as well. 2/3 of the patients were, and a third were triple vessel bypass, and 2 patients we did do 4 vessel CABG with bilateral ITAs. There were no conversions to off pump and no conversion to sternotomy. We did not lose any patients in hospital. One patient had no patients had a stroke. One myocardial infarct post-operatively. We had no superficial or deep chest wound infections, and the overall efficiency was about 97%. So to conclude, off-pump mixed cabbage with bilateral ITAs is feasible and can be safely and effectively performed with excellent short-term clinical and angiographic results in selected patient population. And with Mario's results over the last 5 years with respect to the radial artery, I think LITA and radial would also be a great combination. And in fact, it would make the operation much easier and faster. So it has the potential to completely eliminate the risk of perioperative strokes, provided we do it off pump and without any aortic manipulation. And the risk of chest wound infections is also low to zero, despite the use of bilateral IT. Drawback is that it has a steep learning curve, and operative times are in the initial phase of one's experience. With that, I'd like to thank you. Especially, I would like to thank Marco for the kind invitation. And I hope that we can see each other in Italy next year in person. Thank you.
Great, wonderful points. Thank you, Dr. Davirivala. And I am happy now to announce Dr. Hussam Balki from Chicago University, who is an extremely skilled and intelligent surgeon who I assume as one of my mentors, and that made me fall in love with the robotic technique as well. So Dr. Balki, please, we're looking forward to your presentation.
Thank you very much, Wouter. Good to see you, Gianluca, as well. I think I have a recorded presentation. Yeah, I think they can just start.
I'd like to thank Dr. Usanio and the organizers for the kind invitation. Today, I'd like to share with you a case of robotic multivessel TCAV with bilateral internal mammary artery grafts. These are my disclosures. Our patient is a 73-year-old gentleman who is status post-liver transplantation and a New York Heart Association Class 2 who presented with severe aortic stenosis and significant 3-vessel coronary artery disease, as can be seen here, a tight mid-left anterior descending stenosis, tight stenosis of the circumflex, including a totally occluded second obtuse marginal and a normal right coronary. He insisted on a sternal sparing approach and was offered a totally endoscopic coronary bypass in association with TAVR. On March 5th of this year, the patient underwent the TAVR a Sapien Ultra 26, which was successful, and he was discharged on postoperative day 1 and placed on dual antiplatelet therapy. On May 21st, 6 weeks later or so, the dual antiplatelet therapy was held 5 days prior to a 3-vessel TCAB with bilateral internal thoracic artery grafts. My colleague, Dr. Torregrossa, has shared with you our technique, setup, and harvesting approach for bilateral internal mammary artery cases performed robotically. This is the summary of this man's procedure. You can see the port placement here. The robot was docked at 9:17 a.m. and undocked at 2:34 p.m. The patient was extubated in the operating room and discharged on the second postoperative day. I'll share with you some details of the case. This is after placement of the stabilizer port, which is the 4th port, and after harvesting of the majority of the right and left internal mammary artery conduits before separation. However, we're on the back of the heart through a wide posterior pericardiotomy, and this is the first obtuse marginal branch that's being stabilized with the endowrist stabilizer and then carefully dissected with low electral cautery and a snare placed proximally. After doing that, we go back more posteriorly and we can see the second obtuse marginal branch, and you can see here this area where it appears to be somewhat soft and suitable for grafting, even though it's a total occlusion. And then after we've defined it, we go back to the front of the heart and find the left anterior descending, and we place a snare proximally here as well. We use these saddle loop snares that are nicely short for endoscopic use. Now, after the right internal mammary artery has been bisected and prepared with intraluminal papaverine, we bring it over to see if it's going to reach the back of the heart, which is my preference to use this graft as an in situ graft. In this case, clearly it will not reach. There's a lot of anterior mediastinal fat and thymic tissue. And so the first step is to basically take a low electral cautery with a shears and a Maryland forceps, and we dissect this anterior mediastinal fat in order to bring the graft through there. Now, in addition, in this case, we opened up the pericardium. This is right at the aortic, ascending aortic reflection at the top, and we're bringing the graft through here into the pericardial space and under the phrenic nerve into the posterior pericardiotomy to see if it's going to reach that way. It does not reach, it's too short. And so then we'll bring it now anteriorly to its final destination, which is going to be to the left anterior descending. And we find that the right internal mammary artery through this approach is well suited to reach most areas on the left anterior descending. So this is the technique for the anastomosis. It's going to be an end-to-side sutured anastomosis. We have a heavy silk stitch to help attach it to the stabilizer. Here, we're just giving it a little bit more room on the ascending aorta so it doesn't kink. We do a short period of ischemic preconditioning, which allows us to bring the instrumentation that we're going to use, the sutures and shunts and whatnot, into the chest. After our conduit is clamped with a small bulldog, we do a spatulation of the distal end of it. We open up the coronary target with the beaver blade while the snare is tight, and then elongate the arteriotomy similar to what you would normally do in an open setting with a pot scissors. And then in this case, we're using a 1.75 millimeter chase shunt. These shunts are very usable, soft, and atraumatic. We start the anastomosis on the back wall or the backside of the coronary artery with an inside-out bite with this 7-0 Pronova double-armed short suture, and then inside-out on the appropriate spot on the IMA, and continue along the posterior wall using the same configuration with one of the 2 needles and working our way towards the heel. You can see the exposure is excellent. This is speeded up a little bit, about 1.5 times, and so it takes a little bit longer than this, but here we're dealing with a little bit of a short conduit, so we're taking our time bringing it down. I always like to use a shunt in the conduit in order to prevent backwalling and to give the IMA some structure while we're taking the bites. Here we're bringing the heel of the IMA down just to the right of the heel of the left anterior descending because of the configuration REMA to LAD. And then once this heel is rounded, we park the first needle into the extrapericardial fat and then move along and grab the second needle. Here you can see we're parking it here in the fat, and then we bring the second needle around and go around the toe of the anastomosis and come to the near side of the coronary arteriotomy. I'll move this forward just a little bit because we have 3 of these to show. Here you can see once we've got a good purchase and the size is appropriate, we can move along a little bit and use the suture. Again, there's no following here. There's no assistant to follow. So it's very important to keep these sutures extremely tight while we're working around the toe of the anastomosis. And then once we've got the toe down, we'll just bring in and take double bites on the conduit and the target. I'll just move this along slightly. As we're finishing up here, we'll continue to do these in 1 bite and then flush the conduit and flush the target, and then take the shunt out and tie the stitch. Here's the shunt coming out, and the suture being tied with an instrument tie. Very easily done. Once the bulldog is off, we assess for hemostasis. As you can see here, it looks like we've got a nice hemostatic anastomosis. Once this is done, we now divide the left internal mammary artery distally, as we had seen before, and now we've got a nice conduit that can reach all the way to the back of the heart. I'll move this forward just a little bit to show it's going to be a similar anastomosis end to side. Here's the stabilizer coming on to the second totally occluded marginal branch. And I'll just show you the close-up here. We kind of prepare it a little bit, and you can see it's calcified up at the proximal end of it here, but there's a nice soft area here where we think we can get in. This is the beaver blade coming in, and we see good back bleed. Native flow is good, which tells me that there's going to be some good reasonable runoff. Here's the pot scissors, and then in this case, a 1.5 millimeter shunt is placed. And then we're going to do the anastomosis exactly the same way. As you can see here, working on the back wall. The exposure to the back of the heart is actually somewhat easier in some cases than the front of the heart because of our coming in from the left chest. And so I'll just fast forward this since we already saw it and time is limited. Now working here on the toe of this anastomosis. This stabilizer is unfortunately not available for the XI robot. And so we continue to use the SI and are still looking for solutions for when we won't be able to use the SI anymore. And other programs are also looking for solutions, folks who have already transitioned to the XI robot. Here we're finishing up this anastomosis, tying the suture. And then once we're done with these two, I like to check the flow, make sure that our end to side anastomoses are good. This is a flow over 100 cc's into this totally occluded vessel, so that's pretty good. And then the REMA LAD is also a reasonably good flow with a PI of 1.5. Once these two are done, I like to mark the sequential side to side. We've done the sequential side to side first, and we've done it last. In this case, we're doing it last. I think it lends itself well to that. Opening the target, placing the shunt, and this is going to be a diamond-shaped anastomosis in exactly the same way that that we did the other anastomoses, just kind of taking into account that the heel of the conduit is going to come in the middle of that posterior wall of the target. And so here's the inside out on the IMA, and then working with this needle that's going to round the heel coming on the posterior wall, outside in on the coronary. And we change the camera angle when we're looking from the top like this. It's a 0 scope, and when we're looking from the bottom of the anastomosis, we use a 30 up scope. So I'll just move this one along a little bit. You can see here placing the sutures around the toe of this anastomosis. Again, the exposure is perfect. We can come in or out with the camera as necessary. It's very magnified, and the precision is quite good on the beating heart even. And then once this is done, the shunt comes out, tie the stitch, and then check the flow both to the single side-to-side graft, which in this case is over 130, and then take the bulldog off of the distal segment and check flow in the sequential graft to both targets. A little bit higher. Sometimes we see it higher, sometimes not. And here is just closing a little bit of the pericardium on the back wall to prevent herniation. We did open it up a fair bit in this case to get all the way back to that second obtuse marginal branch. I will stop the video here since I'm probably over time, and thank you very much for your attention. I'll be happy to take any questions. Thank you.
I didn't include any data. We've presented our data at various other meetings, but we can address some of our numbers during the discussion time.
Sounds great, Sam. As always, amazing presentation. Thank you so much.
Impressive surgery. Moving up to the last speaker for today is Dr. Babliak from Ukraine, who will talk to us about his 10 lessons from T-Krat cabbage. Dr. Babliak, are you there?
Dear Chairman?
Yes, we can hear you.
Yes,
but
thank you. Thank you very much for the invitation, dear Chairman, dear colleagues. I am very happy to share our experience and those lessons that we have learned in 500 cases of minimally invasive multi-vessel cabbage. And that some techniques that I have developed 4 years ago is different from other techniques of minimally invasive cabbage. And I call it TC-RAD. So it's total coronary revascularization via left anterior thoracotomy. And we do it through the anterior mini thoracotomy in the fourth intercostal space, and we perform all the anastomosis with the cardioplegic heart, and we use the usual coronary instruments, and we tie all the knots with fingers. So the most important lesson that we have learned in 500 cases is that we can do TC-ROT in almost every patient with the ischemic heart disease. So all the age, low ejection fraction, and large body weight are not the contraindication for TC-ROT. So the only contraindication is the porcine aorta. And the most important technical thing that we have learned that we can easily expose all the coronary targets on the heart. So this is the exposure of EPDA, and this is the exposure of circumflex. And to make this nice exposure, we put the loops around the left pulmonary veins and around the inferior vena cava, and we place them under the heart. Same good exposure we can obtain, and for the proximal anastomosis if we need. We always open the chest in the fourth intercostal space. And the most simple way to harvest lima is to transect the lima in the same intercostal space and harvest it up to the end. So almost in all the cases, it will reach up to the apex. We have no conversions in 500 cases, and despite we have the complications and the perforation of the left pulmonary veins, we were able to repair it from the same thoracotomy. So even if you don't see the hole, you can open the chamber and you can repair it from inside. TC-ROT is definitely more complex and some longer procedure than the CABG through the sternotomy. But if you do TC-ROT every day, you can do it in 3 hours, like with the median sternotomy. However, the mortality and stroke risk is also low, and we think that this is because we do CT scan for every patient, so we know where is the safe place to cross-clamp the aorta, and if the abdominal aorta is very poor, we go to the axillary artery. And that is the video why we do TC-ROT, because this procedure is much more comfortable for patients, so they feel some better and they recover faster. We trying to do follow-up for every patient, but despite we did only for 35% of patients, we confirm close to 100% lima to LAD patency. And this is the last message. So if you are comfortable with the TC-ROT procedure, and if you already did some other minimally invasive procedures, you can combine them. And what we found that 2 mini thoracotomies are better than 1. And also you can combine some TC-ROT with more complex procedures like TC-ROT and left ventricle aneurysm repair. So This is the end. Thank you very much for invitation, and I am happy to answer questions.
Thank you so much, Dr. Babliak. Thank you for everyone to join us. I think that the first things we should do right now is immediately go back to the ballot. The questions that we originally asked, we will ask you to vote again. First question here, open the ballot, is do you think a minimal invasive CABG program would add value to your own institution? After seeing this presentation, please make your new choice, and you can still vote using your right bottom click. The ballot will close soon, and we will launch the second question immediately after this one. Wouter, do you think people will change their opinions? We will see soon.
It has been a very intense program. I'm looking forward what the effect will be indeed. So let's go to the second question. What will be your favorite approach for Lima harvesting? Please vote right bottom of the screen, and we're looking forward to the response.
Indeed, I think that all of the team have done a great job in presenting the different techniques, robotic and direct vision. And after that, we will go directly to ask some questions to the faculty that will join us soon for some questions.
And many questions indeed have been raised. So thank you for that. For the sake of time, we will not be able to go through all of them, but many good questions came up. So certainly thank you for that, and do not hesitate to contact people if you want to have more information, of course.
We will ask immediately the technical team, to bring us in the first panel discussion, Dr. Mario Gaudino and Dr. Cefarelli, if they can come up in the main panel with us. I wanted to ask immediately, Mario, when was the last time you used Rita?
I think last Friday. I mean, I am not necessarily a radial artery guy. I'm just saying that the evidence is stronger in favor of the radial artery, but there are patients where the Rita is a better choice. So I don't think it's a competition between the two conduits. I think you should use the right conduit in the right patient.
This is great, because I think in the last 2 years I felt this mixed feeling with about the Rita, and I'm very happy to discuss about results of the data that are coming up. But I think it's very important that you're saying this one as a message. Mariano, you did a fantastic presentation. I want to congratulate you. You always pointed up something that a lot of surgeons really don't care much, that is the vein. We always feel this is something for the residents, something for the physician assistant. We don't take ownership. And at the end, when you're doing a CABG in a complicated patient, it takes 2 hours longer because there's not a good quality conduit that comes up to the table and you are ready to sew. So what was your training curve? When do you suggest a young surgeon should start to learn about this technique? Very quickly, when did you start?
Thank you so much. As soon as possible. As soon as possible. Yeah, this is my answer. Great. So of course, you can. I mean, you have to be considered an expert officer after about 100 endoscopic vein, of course. But I think that after the first 10 or 15 vein, you can start alone, slowly, but alone you can. So as soon as possible.
Thank you so much. Last question for Mario. Mario, where do you see the future of minimal invasive coronary bypass grafting?
Well, I think there is definitely a future for minimal invasive coronary bypass grafting. I think the main advantage is honestly avoiding external wound complication, which is the Achilles heel of CABG. However, it is my strong belief that you cannot compromise the completeness of the revascularization and the quality of your anastomosis to do minimally invasive, because the real difference between CABG efficient PCI, and the only advantage that we have compared to the PCI guys are completeness of revascularization and patent graft in the long term. So if you compromise these to minimize the approach, I think that's a mistake.
Thank you so much.
Thank you. That's a good and clear message. Let's, for the next discussion, could we bring together Dr. Nambala, Dr. Davirvala, and Dr. Babliak? So thank you for your excellent presentations. There were many questions in the group. Some questions according to the technique. For instance, Dr. Nambala and Dr. Davirvala, I think, in your approach, what are the tricks you use to reach the posterior or an inferior wall?
Firoz, you can take
So, yes, so as I showed you all that I had to just show a very short video, but as I showed you all, like I personally use the armless starfish approach, which gives a lot of versatility to the positioning, at least in my hands, and I think Mark Ruel and also does the same. But Satyaki has been doing it with the conventional Medtronic, I think, starfish, which goes through the subxiphoid, and he's capable of doing it as well. So I think it's more to do with what you are used to. Every approach is correct and good as long as you can do it well. And the important thing is to go and see various experts in the field do the operation and then choose the one which best suits you.
Super, thank you.
That is correct. I think Firoz put it very well. Ultimately, it's about how you develop the technique for yourself after watching many people. So I use the Starfish NS, and you can actually expose every vessel on the surface of the heart. I think what's extremely important is that you place the incision rightly. If you were to place the intercostal incision higher up, it's very difficult to reach the posterior wall. So if you put it on the fifth space, approximately corresponding to the apex of the heart, you can simply put the starfish on the apex, move the heart, or the apex of the heart towards the left shoulder, and you should be able to see the posterior vessels beautifully.
I think these are excellent tips and tricks. And Dr. Babliak, also for you, we have seen your technique, which is very adequate and to the point. Some people were questioning, do you experience a lot of problems concerning pain post-operatively, and how do you deal with this? We all see some pericarditis. Do you experience a lot of pain in your patient, or is this very limited?
No, I should say our patients are very comfortable with this procedure. Of course, our anesthesiologists, they to use PEX blocks, but with the anterior thoracotomy, we have some less incidents of the broken ribs that when we did the lateral at the beginning. So we started to the lateral, and then we went more with anterior. So even if you have some broken some cartilage, it doesn't cause as much pain as some broken ribs. So
thank you.
Okay. Thank you very much for this input. We have to move forward. Gianluca, let's invite the next.
Dr. Sam Balki. Sam, we have been in a discussion many times when I was there with you since just a couple of weeks ago. We have been, tell us why do you think what we have done wrong as a community of surgeons to do not convince people that there is such an incredible value for multi-arterial bypass grafting with a robotic platform. How can we overcome the limit? We have seen industry disengagement, both from the robotic platform and the distal anastomosis connector platform. What we can do to regain position in this that is a niche that makes so much sense, not splitting the sternum, maintaining the proximity of the Rita, offering multi-arterial bypass grafting, and have a perfect view of the distals and the Rita takedown. What do we do? What we move from here?
Thanks, Gianluca, and thanks, Wouter. I'd like to also thank Professor Diosano on conducting a wonderful meeting. And I think the answer very simply is do more of this and really get the word out that this is doable, that there is a new generation of surgeons exemplified by yourselves, our two moderators today, that are engaging in this field and are very interested in taking full advantage of the technology that these surgical device companies have to offer. And it's a shame in our specialty that we have not availed ourselves of all of the different technologies over the last 10 years that other specialties have. And the results are very clear in that industry is stepping away from our specialty. And so I think lobbying surgeons all around the world and getting them interested in a less invasive approach. I think Wouter said it very, very nicely in his presentation that we will be boxed out of surgery and out of interventions for various heart problems if we continue to do sternotomies and continue to do large incisions. And there is technology that has been made available to us that allows us to do it totally endoscopically. And it's not impossible. It's not a huge hill to climb. It's just methodical, stepwise approach and can be done. And so I think more sessions like this, more education, more teaching. And I feel a different, I gave a talk at the STS called the Renaissance in Robotic Surgery. And it's not just coronary, it's also other heart procedures. There is a renaissance in robotic surgery on the heart. And I think it's the younger generation that's going to lead it.
Thank you so much, Sam. We all think that is what you're saying is so important. We will definitely willing to see more training. We think that this is so important for all of us because there is a young generation of cardiac surgeons that wants still to be relevant and be relevant for treating stable coronary artery disease in a less invasive approach. And we have all seen that cardiologists are actually embracing the concept of hybrid with enthusiasm. So it's something that we should promote and keep promoting more and more. So we want to provide the results of the ballot. I think this can open a little bit of discussion if we have a few minutes more. We can see the first questions, the results of the first question before and after the presentation of our faculty. The first question was, do you think a minimal invasive CABG program would add value to your own institution? And well, this is so before faculty, there was 100%. After, probably we scare some of the people, and 4% said not really, complete revascularization is the only way, and 4% yes, probably, but not cost effective. And I think that the cost effectiveness is something that shouldn't be worried in the sense that in at least some part of the world, robots are readily available, or technologies as example by Direct Vision has been proved to be adopted in every country with every type of healthcare and resources availability. And for complete revascularization, my message is that this is not really wants to compete against anatomy CABG, wants first to define its role in treating coronary artery disease to complete the coronary. Wouter, do you want to make some opinion about?
Well, one last point. I think if indeed these are the things that are scaring off people, I think key is investing in training, publishing results. This is so important, and training all the young people that are there to have the very high quality anastomosis for every step that they take. The quality will be the only message here and the only thing to change things in the future. And then let's go back for the last ballot indeed. What will be your favorite approach, if we can still have it, for the Lima harvesting? So interesting results. A lot of people are started here with direct vision view through sternotomy or mini thoracotomy, but I see a huge increase in robotic interested people. So three-wise increase. That's quite a lot. While the sternotomy seems to be reduced a lot. So I think minimally invasive options that have been discussed today. I think every presenter reached his goals and his public, and I think there are many ways to Rome, as we are in Italy or virtually in Italy. And we need to combine the best ways and all the teaching techniques that we have to get there.
This is great, Wouter. I want to say thanks to all of our faculty who joined us here today. Thanks to Marco Diosanio and to CTSNet for this incredible opportunity. And we want to do not delay any further the aortic component of this meeting. So please back the word to the organizing committee. Thanks again, everyone, for being here. Thanks for attending and participating at the ballot.
Thanks to everybody. And next time we'll see each other live.
Thank you, Wouter. Thank you, Gianluca, for the great job. I knew I had the best chairman and the best speaker I could wish, but I could not expect such an amazing session on minimal invasive coronary artery bypass grafting. I thought it was important to show that in our meeting. But we have to move on. We have to move on to the next session that is focusing on minimal invasive and Trans-Catheter techniques for the treatment of patients with aortic aneurysms. We have two chairmen that don't need any introduction. One is, well, I see the names are not correct here, but one is Joe Bavaria from Penn University. This is a kind of game here. From Penn University, past president of STS. He is also many other things, and I'm really happy to have him with us. Let's go back, please. And also the second chairman is Dr. Eric Coselli. Again, he has no need for any presentation from myself. He's the director of the Cleveland Clinic. This looks right now. So I think the right name under the right person here. So I think we are ready to start with this session. Please, Joe, please, Eric. We're just looking forward to your session. Thank you.
Well, I hope you can hear me. Thank you very much, Marco, for allowing Eric and I to chair this session. The session is an aortic session, and we have a nice lineup of excellent speakers and excellent topics. At this point, I'll turn it over to my co-chairman, Eric Rosselli, from the Cleveland Clinic, to kind of launch the ballot. Eric?
Thanks, Joe. Thanks, Marco, for putting together such a wonderful meeting. I really enjoyed that coronary session. That's as we move on to the aorta. If you could bring up the first question for us from the ballot, we'll go through the first couple of questions, and then maybe we can talk for a bit, Joe. Surgery of the thoracic aorta will most likely progress through the development of A, minimally invasive surgical approaches, B, hybrid techniques, that is open surgery combined with catheter-based techniques, C, totally endovascular approaches, or D, probably the least progressive one, just continuous refinements of current open surgical techniques. You can go ahead and vote for what you think there. We'll give a little pause here.
I see you interjected a little of your own bias there.
Well, that last one was a little slow for us, as I've been assigned to talk about 2030, Joe,
Exactly.
Why don't you tell us about the second question, Joe?
Okay, so it looks like the votes have been tallied for the first question. So the second question is, what is your favorite approach for aortic arch repair? Open with a standard total aortic arch with a classic elephant trunk, or secondly, hybrid one, which is a total aortic arch with frozen elephant trunk, the FET technique. Hybrid 2, which is some sort of debranching technique, or zone 2 with a TVAR placement, or 4, total endovascular aortic arch repair. So you can please vote. Looks like the ballot is closed. Okay, well, listen, we will come back to these questions at the end. And unless Eric has a comment he wants to make.
No, I think we should go ahead. Marco already did the introductions of us, Joe.
Okay, well, our first speaker is going to be our co-chairman, Dr. Eric Rosselli, who is going to be speaking on root and ascending aortic repair in 2030. Eric?
Thanks, Joe. Several disclosures are shown in this slide. Some of them are relevant, some of them not, but I will be speaking about some off-label and investigational use of devices. I think first we need to step back and just look a little bit at what thoracic aortic surgery looks like in the current state. We know that our Japanese colleagues have been sort of ahead of the curve when it comes to doing complex thoracic aortic surgery. In this analysis of a Japanese database, you can see that most of the surgery did involve the ascending and the arch of the aorta, with a smaller percentage involving the root and thoracoabdominal and descending aorta. And operative mortality was 8.5%, 7% for root surgeries, with a 30% rate of major morbidity. The risks associated with this included emergency surgery, no surprise there, and other comorbid conditions like renal dysfunction, or if a patient needed additional coronary bypass surgery. Now we look in the US and we've seen some STS analysis of data. Here they looked at total roots and AVR and ascendings. And interestingly, 25% of the operations were performed at 3% of the centers, which also took on more endocarditis and more of the redo operations. And when they broke it down to volume, we could see very clearly a volume to outcome relationship, where higher volume centers that did more than 30 of these operations a year had half the mortality of the less busy aorta centers. Well, this is what a complex proximal aortic repair looks like: ascending hemiarch, total root replacement. You can see we've got this novel biobental composite graft that we're sewing in place. And maybe in 2030, I'll be able to do it this fast, but I doubt it. So this is what kind of conventional surgery is going to look like for a little while yet. But we'll be moving, just like we have in valve surgery, towards less invasive approaches. We've been doing this in Cleveland for quite a while. Melissa Levack wrote up our experience, and you could see in this trend curve that over about a decade, a significant number of our operations were involving less invasive approaches for the proximal aorta, and about 14% of those minimally invasive even included things like a total root replacement. We have done a few arches through these less invasive incisions, but most of it's ascending aorta plus or minus a valve and a root. Now, we've heard about minimally invasive approaches for aortic valve disease, and we know that this right thoracotomy is probably even less invasive of an approach than a mini sternotomy. But I got to say, it's probably only a really good exposure for the valve and maybe an aortic root in select patients. We like to use CT guidance for that. In general, we're talking about more complex thoracic aortic surgery. I don't think that the mini thoracotomy is really a great way to deal with patients who have extended disease. However, the mini sternotomy really is. And again, one of the things that we've demonstrated and we found to be really important is the use of this complex imaging, where you can get a virtual view, as you see here, where you can kind of cut away what a mini sternotomy in the third, fourth, or fifth interspace looks like, so you can see how much of that aorta you'll have exposure to. And that's really helped to guide us in our decision making about how to treat these patients. This is another sped up video of what one of these mini ascending aortic replacements look like. It's about a 7 or 8 centimeter incision. We'd like to do central cannulation. And again, in the properly selected patients, we can excise that ascending aorta by kind of working back and forth between the proximal and the distal end. We can still replace a full ascending aortic replacement that we're happy with and get a good result. And we can even do some circulatory arrest cases. Here's a hemiarch under circulatory arrest. We've got really nice exposure to the distal aorta. In this one, this was a straight circ arrest hemiarch. Sometimes we'll cannulate, and we can even do selective antegrade brain perfusion during these operations. As we get better hybrid devices, that may be another way to approach this. And you can see we can even do pretty complex root surgery. Here's a patient who needed a bicuspid valve repair and had a dilated annulus. So I was able to dissect out that whole root, get around the coronary arteries, and place an external annuloplasty band that you can see I tied around Hagar dilator. We got a really nice bicuspid valve repair. And so we can do complex root surgery through these mini sternotomy approaches. A very versatile approach, and I think a good way to handle a lot of things. We've seen from the group in West Virginia recently, they've even used the robot to assist in aortic valve replacement in a series there that they've moved through in a very deliberate and scientific way that they've studied it. But of course, there's increased cost. Question is there some increased risk? It depends on what you're doing, and will there be some benefit to doing aortic surgery through this? Again, just like that right mini thoracotomy provides you limited access to what can be pretty extensive disease, I'm not sure we'll be going robotic as much as we'll be going endovascular, and we'll be hearing about that from our colleagues going forward. Certainly, endovascular may be a way to approach these patients where we see there's an unmet need, like this group of patients with high-risk type A dissections who get turned down for surgery. We've treated some of these patients with off-label use of devices. You can see as we're seeing more and more TAVR being done in more complex patients. We've had a couple of these. The one in the middle was someone who was 6 months post-TAVR who showed up with a dissection, and we had to get pretty creative with a bunch of stuff we took off the shelf to get this thing repaired. And then this was another patient who dissected right on the table, and we recognized it and treated that patient with off-label sort of use of TEVAR in the ascending aorta. Ideally, we'll have something that sits better in the ascending aorta, and I'll talk about that in just a minute as we're starting to get site-specific devices. Here's the guy that had the dissection that happened in the OR. We can see he had severe AI on the image on the right. And after we deployed the device, the AR was from the stent graft compromising flow across that valve. So I had to reposition that device. You could see that balloon dragging that thing through the ascending aorta. Pretty scary thing to do, but was necessary in this patient who still had severe AI because the device was compromising the function of that new TAVR valve. But after positioning, get a sense of how low we could and needed to go, we were able to do that. We put a second device in and got a good result in this patient. But I show you this example because it's a demonstration of where we're failing with, using off-label devices and why we need specific devices that can really provide us this coaxiality that we need to be very specifically positioned along the sinotubular junction of the aorta. We certainly learned in our analysis of our off-label experience that the location of the disease and the location of the ascending aorta is relevant to how the patients do. The more proximal the disease, the more proximal the treatment, the worse the patients. You can see the 0A is different than the 0C patients. But now we have this new ascending stent graft device. We've pretty much completed the early feasibility study, and we're working with the FDA to put together a pivotal study. And the cool thing about this device is you can be very accurate. As I'll show you here, it's got a partial deployment and staged deployment. So see, we partially deploy the device in the ascending aorta, which allows us to have some of that further maneuverability. There's still flow around it, so there's no compromise. We can keep the heart beating at a regular pace and take our time. And then we can shape the lesser curve. So you see in the little video on the right in a model, how by cranking that, you can give this stent graft a curved shape and pull that inner curve up away from the coronary arteries or away from a TAVR valve, like the case that I showed you. You see the green arrow is pointing to that device that's used in an actual patient in the study, how we can get that aligned. And then the next phase of the delivery allows us to fully expand the device, which we usually will do with rapid ventricular pacing. And then after that, there's even the opportunity to angle the proximal edge of that device a little bit further if we're worried that there might still be some compromise. So we can be super accurate with this device. It's modular, and it comes in multiple different sort of components and sizes, and we're going to see that technology moving forward. What about the next phase of where we're going? Are we going to have an endocomposite valve in 2030? Well, we had this concept in 2010. Both Lars Svensson and Roy Greenberg issued patents about potential designs for these things. And in 10 years, we've seen it come to reality. My friend Diego Gaia in Brazil presented this in JAC in 2020, where they actually did one of these devices in a very highly selected and complex patient, and they were able to get a good result. Will it continue to develop? I'm certain it will, and we'll have to learn kind of how and when and who that will be applied to, because there's issues with proximal fixation and seal and the issue of coronary patency. Now, for coronary patency, we have these covered stents that are designed for perforations, but we have to appreciate the fact that proximal fixation and seal is difficult to obtain in the annulus. We see even with the very best and novel transcatheter valve devices that mild paravalvular leak is routine, and that will not be good enough in a patient when we're trying to seal an aneurysm. So we'll see where that technology is going to go. But in 2030, I think we need to think about embracing all of these ideas about tailoring the care to the patient. We have to understand the details of their aortic valve and their aortic disease. We need to understand what are their non-aortic comorbidities. And then we have to look internally at our own experience with various devices and our surgical results, always focused on the patient. And then as these new technologies become available, whether it's minimally invasive access or novel devices, we'll have to learn how to apply those. But I really think something we should strive for in 2030 is the goal of zero elective mortality. There's no reason we can't do that, just like we strive to do that with mitral valve repair when we're talking about doing prophylactic operations for patients. Thank you very much, and look forward to further discussion and a whole bunch of other great presentations in this excellent meeting.
Well, thank you very much, Eric. That was outstanding, especially some of the aortic stent graft technology, which I know will definitely be coming across our boards over the next decade, without a doubt. So everybody who's an aortic surgeon should beware. I think I'm going to be giving the next talk, right, Eric?
Yeah, Joe, you're going to talk to us about aortic arch repair in 2030. Sounds a long way away, but maybe not. Fire
not
away.
Too much.
We all know who Joe Bavaria is. He's a leader in so many ways in our field, but also on the cutting edge of everything aorta. So please, Joe, teach us.
Perfect. Thank you, Eric. All right. So my assignment today by Marco was the aortic arch surgery in 2030. So let's move along. These are my disclosures. So really what I'm here to tell you is something a little bit like what Eric just said, which is that I'm to tell you that we're at the beginning of an aortic arch revolution. And we'll try to detail that here. Recently, when I mean we, I'm talking about the aortic community, spent much energy and time trying to optimize and answer the question, what is the best circulation management technique during aortic arch reconstruction? This has to do with temperature. What is the particular kinds of circulation management, hypothermic circulatory arrest, retrograde, antegrade, unilateral, bilateral, et cetera, et cetera. And the optimization key concept was that the mortality and morbidity of short arch reconstructive times, say less than 30 minutes or so, is an embolic phenomena, which is a lateralized stroke. The mortality and morbidity of longer arch reconstructive times, say greater than 30 minutes or 35 minutes, is a global neurological deficit. So the general consensus on circulation management and its complexity at this time is that tepid temperatures are reasonable with good ACP techniques. ACP is thought to be the best. Retrograde is reasonable, especially for short arch reconstructive times, and that maybe HCA alone should be abandoned. This is kind of where the data has been for the last decade. And also that we need to understand what we're doing. This is an example of cerebral oximetry, which is now a gold standard for aortic arch operations. But now we are changing practices and really developing reconstructive operations based on the availability of new devices and new technology. This is the critical concept going forward. So what about aneurysm? So this is a typical aneurysm you can see here in the chest, a large ascending and descending aneurysm. How are we going to go forward with something that looks like this? Well, the bottom line for aneurysm is that all open proximal operations will be performed with an attitude looking towards distal TEVAR solutions. This is key. The classic elephant trunk will be rare. Frozen elephant trunk, or FET, will be victorious. All conduct of operation will be geared towards proximalization into zones 2, 1, and 0, which is kind of a newer debranching concept. What about the aortic arch in relationship to type A aortic dissection? Well, one of the things is that we know that we've designed an operation over the past 20 years, which has been a very good operation, and it has addressed the major causes of death from the valve, from malperfusion, from rupture. But one of the things that's a problem with it is that it has ignored the fate of the distal descending aorta. And these are some operations that are some series looking at just reoperation rates for the most part that really range between 16 and 30 and 40%. And the Ishihara one and the second one from Japan, which is a good one because it looks at total aortic events, not just reoperation, 27% at 5 years. This is the real deal. And this is the 39% reoperation at 10 years from Glauber and Mersey. So what about late outcomes after DeBakey type 1 repair? Well, most of us have seen thousands or hundreds of these types of pictures. Here's a guy, 6.4 centimeters, 1 year after type A dissection repair, a successful repair. Here's another one with a 7.3 centimeter at 10 years. Again, a successful proximal repair. And we know from some of the data that we've done in the research laboratories, engineering laboratories, that a secondary tear site after type A dissection in the proximal DTA is the point of large stress formation, as you can see in the red, where there's rapid expansion. And you can see what happens where you have these large aneurysms like this at just 2 years. So, do we have a problem with the distal aorta after repair of acute type A dissection, especially DeBakey 1? The answer is yes. And this is a very important point. This is especially true if we use a composite of index operation failure, which we probably should do all the time, of aortic death, reoperation, and aneurysm greater than 6 centimeters. Okay, we can't just use reoperation alone. So acute DeBakey type 1 dissection is a total aortic catastrophe. It can be stated no other way. We must address this issue if we are going to improve outcomes. How? With TEVAR enabling solutions at the aortic arch. What can we do? What options are available? Well, we looked at this. This was just right before the pandemic. I was moderating an arch discussion with Dr. Ruggiero DePaulis from EACTS, and we looked at this question. Well, we can always do what we've been doing, which is the hemiarch operation. It's a very good operation. It's a pretty good standard. However, we know that operation leads a little bit to be desired distally. I believe that the future arch treatment kind of nice Civil War is really going to be between The frozen elephant trunk operation is a ubiquitous operation for type A dissection, as you see here in multiple arch FET concepts. And also looking at what we call the zone 2 arch with sequential branch TVAR completion. This is the idea of using branched TVAR. So we have these two incredibly potent and powerful technologies, the frozen elephant trunk, as well as the branched endografts. And the advantages of the zone 2 arch with sequential branch TVAR is that it's simpler. It can address most complex arch tears. We have shorter times at the arch. Definitive TVAR options are available, less incidence of recurrent laryngeal nerve injuries and phrenic nerve injuries. And it's actually not doing an unnecessary distal procedure at the index operation, which we know happens 30 to 40% of the time. And it's also from the Griepe-Etz collateral network theory that it's friendly to that theory. And this is some examples of using TBE and Mona Lisa. Here's an example of one of our cases, just looking at this, where the index operation is a zone 2 arch, and you can see rapid degeneration of the proximal descending aorta into a big aneurysm within 10 days, and then the placement of a side branch and branched endograft later on in the far right panel. The big picture is that the classic type 8 operation is under siege. There are reasonable arguments to extend the operation both distally and proximally, actually, with, say, a David 5 operation. However, the arch and the distal imperative is more important. So I believe, at least from the arch standpoint, is that in patients that have a life expectancy of less than 10 or 15 years, we're still going to be using the classic hemi-arch operation for type 8 dissection and others. In patients with an arch tear or a distal malperfusion, the frozen elephant trunk is the proper way to go. However, in patients less than 65 and patients that are relatively stable from a type A dissection standpoint, the zone 2 arch with possible sequential arch branch TVAR, utilizing these new branched endografts, will probably be a very, very important adjunct to our armamentarium. One of the rules that I like to talk about regarding TVAR in the chest is that the TVAR universe X is a descending thoracic aorta aneurysm, 2 to 3X is type B aortic dissection, and 4 to 6X is type A dissection. Type A dissection is the holy grail. So what about aortic arch TVAR? Well, one of the things is that arch TVAR as a whole is focused on isolated arch pathology. And this is an area where you have a normal landing zone in the ascending aorta and a normal landing zone in the descending aorta. Well, here's the problem with that. This anatomy only represents 1 to 3 of all arch cases, 1 to 3% of all arch cases, as noted in many of the thoracic aortic surgical databases. As you can see here, these saccular aneurysms are aneurysms of the mid-arch. So they're really not a very, very common condition. And here's an example of using arch grafts. This is the Bolton medical graft. Here's another example of it utilized in a previous dissection case. You can see the 2-branch Terumo-aortic Bolton graft. This is from our own institution using the EFS trial. And also the Cook experience, worldwide experience, using the arch branch graft, which is probably the biggest experience. And here's the zone 0 solutions. This particular one is with the Gore zone 0 device, but there are other zone 0 devices as well with single large innominate branches. So there are many options. However, we have to remember that isolated arch pathology is very rare. Almost all aortic arch pathology is in combination with either ascending or descending pathology. As you can see here, which is the reason why placement in these hybrid operations, placement of a proximal graft for the TVAR to dock into or land into is the preferred solution with the best results. Now, there is a dark side to endovascular arch approaches. This was looked at the EACTS meeting with Thilo Kobel from Hamburg, from vascular surgery as well. And this is from a big review in 2018. And the bottom line of this review was that the zone 0 and zone 1 results were probably not quite ready for prime time. The total stroke rate in this review was 18%, paraplegia was 3%, retro A was 3.3%, and type 1A endoleak was 7%. So this is actually probably not very good. However, it is getting better. So the facts are that the technology is extremely promising, and our Pen Aorta group is presently involved in 5 trials of ascending arch TEVAR, so we are really full in. However, we need to make sure that the results are reasonable, as CVA stroke is a devastating complication, and most of my patients would rather be dead. Well, TEVAR for ascending primary pathology was discussed a little bit by Dr. Rosselli just now, but there are significant arch landing zone issues which he discussed. And you can see that in a case like this, which I presented, there are no proximal landing zones anywhere. And in this case, which is an ascending, there are no proximal landing zones. You're going to have to do an ascending replacement. And just look at the water hammer pulse of the AI aneurysm. This is actually a very hostile territory for ascending and arch TEVAR. Can type A dissection be initially repaired with an ascending arch TEVAR? Well, we do have new devices and new trials. Again, at the ascending component, Dr. Rosselli looked at this, but most of this will actually end up having an arch component as well. And here's an example of a type A dissection treated with an ascending component, as Dr. Rosselli showed, but also at the same time an arch component as well as a DTA component for a full aortic type A catastrophe reconstruction. Now, one of the things that we have to do, though, as an aortic surgical community, certainly by 2030, is to make sure that we're doing the right thing and doing good work. And that will require an audit function. And I want to use this opportunity to say that we do need thoracic aortic surgery specific databases. This is one of them from the STS, of which Dr. Rosselli and myself, as well as many others, are on the committee. So in conclusion, probably the hybrid operating room is going to be a part of thoracic aortic arch work in the future, as well as ascending work, as Dr. Rosselli just showed. Index proximal aortic operations will be driven and conceived by the new availability of new technology endografts, zones 0, 1, and 2 TEVAR branched arch grafts. Proximalization of the arch, conductive operation will continue. This reduces nerve injury and is collateral network friendly, and it does enable TEVAR solutions. The index operation tactics will be driven to reduce total cardiopulmonary bypass time. It has been shown that this is more important than actually circ arrest time. And very importantly, I think, for our community, it is too early to have guidelines on aortic arch surgery. It's just too dynamic of a stage in this part of our history. The only thing we probably should do is outlaw HCA alone. And lastly, we do need better outcomes data. This is a global responsibility. Thank you very much, and I'd like to always end up with the great quote from Juan Perotti, that the best care is provided by specialists who are great open surgeons and great TEVAR surgeons. Thank you.
That was a fantastic review, Joe, and really helps to set the stage, especially in the group of patients with aortic dissection, which adds a whole nother level of complexity. Not only is that branch segment in the upper part of the chest, the arch, particularly complex one to handle, but the thoraco-abdominal segment of the aorta is as well. And many of the lessons that we've learned from endovascular surgery sort of started in the abdomen and worked their way up. And so our next speaker is Roberto Chiesa. I believe we're going to save our discussion till the end, right, Joe? So
that is correct. Yes.
We'll introduce Roberto Chiesa from Milan, who also needs no introduction, as he's had a broad experience in treating all aortic disease, and is going to talk to us about the future of thoraco-abdominal aortic aneurysm repair in 2030. Roberto, hello.
Hello, how are you? A pleasure to meet you. How are you, Bavaria? Pleasure to meet you.
Thank you, Roberto. The floor is yours.
I think that we start as soon as possible.
Thank you, Professor Rosselli, for the kind invitation to this second edition of Ancona Live virtual course,
2021, and for the privilege to present how will be thoracoabdominal aneurysm repairing in 2030. I have no relevant disclosure to this presentation. A brief historical overview. This is the Houston Medical Center, where everything about thoracoabdominal open repair started during the 50s. De Becky and Cooley first reported in 1953 a case report of thoracoabdominal aneurysm open repair performed with clamp and sew technique using nomograft. And after 2 decades of evolution, Stanley Crawford introduced the inclusion technique. TAA open repair today is still a complex procedure with the need of a multimodal approach. And many adjuncts play a role in this scenario, such as cerebrospinal fluid drainage with LicoGuard, which allow a simultaneous automated liquid pressure monitoring and an active drainage. Motor and somatosensory evoked potential offer a real-time spinal cord function monitoring during the intervention, with the possibility to perform prompt adjunctive maneuvers in order to prevent spinal cord ischemia. Renal protection is another key factor in TAA open repair, and we started some years ago to use custodiol for intraoperative renal perfusion. Custodiol cold solution is associated with lower postoperative acute kidney injury rates when compared with ringer solution, as recently demonstrated by our randomized double-blind Curitiba trial. Intraoperative routinary use of Rotem provides crucial information on fibrinogen levels and fibrinolysis, resulting in a significant decrease in transfusions and cost, and also pulmonary complication rates. Since 1988, we performed 1,159 TAA repair. We compared 2 groups into different time periods. Group 1, 455 patients, performed from 1988 to 2010 without use of adjuncts. Group 2, 704 patients, performed from 2010 to 2021 with routinary use of adjuncts. With routinary use of adjuncts in Group 2, we have a significant reduction in terms of mortality and spinal cord ischemia, and also reduction, not significant, in terms of renal failure. Nowadays, endovascular procedures represent a valid alternative for TAA treatment. Since the early 19, from the first EVAR, endovascular approach had a continuous and rapid evolution. And after only 30 years, today you have many different stent grafts and solutions to treat the patient with custom-made device and also off-the-shelf device. New material offer lower graft profile, and preloaded grafts allow an easier target vessel catheterization. The use of these adjuncts has led to an extension of the feasibility of endo repair. But our indication has changed through the years. In the early 20, all switchable patients underwent TAA open repair, reserving endo only to unfit for surgery patients. Today, open surgery is indicated in fit patients, connective tissue disorder, adding conversion after filed endo, and endovascular repair is performed today also in fit patients in selected centers. But where we live in 2030, this famous man, Elon Musk, told us that in the near future we will live on Mars, but thoracoabdominal disease will be present also there. And we need new adjuncts to treat thoracoabdominal disease in the future. Future perspective will involve medical therapy, open surgical repair, and endovascular repair. A new frontier in medical therapy might be the genetic therapy able to correct pathogenic mutation in Marfan syndrome and other genetic disorders directly in the human embryos by base editing use. In open surgical repair in 2030, we will rethink the concept of age and aging. With the increase in life expectancy, the 70s will be the new 50s. You could see an improvement in robotic surgery techniques that could eventually involve also TAA treatment. Robotic surgery already plays a role in abdominal aortic surgery, and evolution also in thoracoabdominal surgery will be difficult but possible. Spinal cord ischemia is an open issue in thoracoabdominal disease. Spinal cord preconditioning with segmental arteries occlusion could allow less ischemic spinal cord injury and better neurologic outcomes. Moreover, new tools such as electrical stimulation are now under investigation and probably will be able to treat spinal cord damage in the near future. In endovascular repair in 2030, we will be able to treat a higher number of patients, also in case of arch involvement, with constantly improving endovascular device. X-ray reduction is of paramount importance today. New devices like a fiber optic viewer will aid in endovascular procedures in order to ensure high precision in lower X-ray exposition and subsequently lower risk for patients and for the surgeons. Another tool, the augmented reality, could also play a role in the future for intraprocedural 3D reconstruction of anatomical structures resulting in X-ray use reduction. With all these new tools, future trends suggest an ever-increasing use of endovascular technique in TIA repair with a widespread acceptance in the near future. However, in 2030, open repair in TIA will still be indicated in fit patients, connective tissue disease, conversion in endofailure. Open repair will be the first choice in fit patients since it provides good early and late outcome. On the other hand, endovascular intervention rate at 2 years in nowadays is 65% and probably will remain high in the near future. In connective tissue disorder, endo in fact has different open issues such as visceral branch stability due to large aneurysm and possible late dilatation of the visceral vessels, and aortic wall frailty stressed by the stent graft, as you can see in these cases where a Marfan patient previously treated with TAVR developed a thoracic aortic dilatation 1 year later, clearly induced by the stent graft. So connective tissue disorder will remain undisputed territory of open repair also in 2030. Open conversion after TAVR will also remain an indication in the future. Today, multiple endovascular failure need open surgical conversion, and this will remain in the near future. Moreover, the widespread distribution of CVAR and BVAR already play a role in open surgical conversion and will be probably more significant in the future. Since 1995, we perform a 92 open conversion after TAVR, and as this histogram shows, the number is increasing over the years and probably will increase further in the future. In conclusion, better knowledge and a new technology will improve the outcome of open and endo thoracoabdominal repair. Endo will increase further in the future. Open surgery repair will always be the gold standard in selected patients. Nowadays, endovascular repair reached a widespread distribution worldwide, but only few centers still perform open surgical thoracoabdominal repair. In 2030, endovascular repair probably will reach an even higher distribution, but who will still perform open surgery? Who will treat these patients on the Earth or on Mars? Me? I hope not. I hope to have some rest in 2030. So, new generation of vascular surgeons need to be forged with both endovascular and open surgical technique in order to provide always the best treatment for this complex and risk pathology. Thank you for your attention.
Thank you very much, Roberto. It was a great discussion and great talk, as well as kind of a little bit of an interesting 2030 prediction. I think what we really want to do is we'll have a discussion at the end, and this is certainly one of the topics we're gonna want to discuss. So our next speaker in the aortic session here is Tristan Yan from Royal Prince Alfred Hospital, University of Sydney, who's going to speak to us on minimally invasive root and arch surgery. Tristan, good to see you.
Good to see you, Joe. Can you hear me okay?
Yes.
Yes. Hi, Tristan.
Hi, Eric. I'm trying to get the clicker to work. 2 seconds. It's waiting for connection.
We can
Here
see
we
your
go.
talk there. Okay.
You can see my talk. Okay. Well, my assignment today is talking about minimally invasive aortic root and arch surgery. So in my practice, the patients with isolated proximal aortic aneurysms, such as aneurysms of the root ascending aorta and or proximal aortic arch, they will be considered for mini access approach. However, there are contraindications, both in terms of absolute or relative contraindications. I don't do mini access surgery for patients with aortic dissection, aortic rupture, or a salvage surgery because absolutely there's no point. And also for patients with extremely large aneurysms, when you do a full sternotomy, all you see is aortic aneurysm. You can't even apply the cross clamp through a small incision, so those patients will not be considered, obviously, for mini access surgery. When I look at a CT scan, I focus mainly on the proximal and distal aortic tissue quality, looking at arthromatous load and also degree of calcification, especially at the cannulation site and cross-clamp site. I don't really pay too much attention in terms of the position of the ascending aorta and its relationship to the sternum and the intercostal space, because once the cross-clamp is applied, aneurysm is resected, it doesn't really matter where the ascending aorta is, because our focus will be down to the aortic annulus and distal aortic anastomosis. We use dedicated aortic surgical instruments and co-developed with Delacroix Chevalier, a company from Paris. And we've been using these instruments to perform all mini access aortic surgical procedures with very good results, and the instruments are quite comfortable to use. I would like to make it clear that I only use the right anterior mini thoracotomy for isolated aortic valve replacement with femoral bypass cannulation with 3 centimeter access incision. And when we talk about aortic replacement, whether it's ascending root or proximal arch or arch surgery, Abraham sternotomy is the preferred approach. The incision, what is comfortable, a 5 centimeter incision is quite comfortable. The sternal division is to the left side, either to the 3rd or 4th intercostal space. In my experience, for patients with relatively moderate size aortic aneurysm, bicuspid aortic valve, the sternal division sometimes is required down to the 4th intercostal space. But for patients with relatively larger aneurysms, a degenerative pathology, 3rd intercostal space will be enough, but it's always to the left side because exposure is much better in the area of aortopulmonary junction. And this incision provides the surgeon safe access for aortic cannulation with antegrade perfusion, aortic cross-clamping, and antegrade custodial delivery. I don't use retrograde, I don't use the right superior pulmonary vein vent, and also I don't use the pulmonary arterial vent anymore. So really, it is a minimalistic approach. But when you expose the ascending aorta at the beginning, you really can't see the aortic root. The key message here is don't panic, because once the cross clamp is applied, aneurysm is removed, you have plenty of room down there to access the structures you want to. So just here is a short video clip to show you this technique with the clamp on the right hand side, another clamp on the left.
We'll be able to get across the lead ascending with one cross clamp. With the other hand, So to gently pull that down.
So
Okay?
gently pull down
You
and apply the cross clamp with
properly.
the left
You
hand
have to make
properly.
sure all the way across.
Because really you can't use your fingers to get around the ascending aorta
On
to
that
ensure
side,
that
away
aortic
from
cross
the
clamp
pulmonary
is
artery
differential.
posteriorly. Cross clamp is applied. Okay, cross clamp
So
is
cross
on.
clamp is applied and the flow is back on. Now, next thing is deliver the cardioplegia to protect the myocardium. Now, it doesn't really matter if patient has aortic stenosis or severe aortic regurgitation. This is my routine way of coming to a diastolic standstill. That is to give an initial dose of antegrade cardioplegia down the aortic route at a very low pressure. You can use a defibrillator as well. Here we go.
Start hard on the vent. Okay, flow back up.
So really empty out the heart,
If you're happy
empty
with
out
your
the
flow,
aneurysm.
let me know.
So once the
So now
aneurysm
we
is
have
flat,
applied the
nothing
cross clamp.
in the heart,
This
no
patient
blood in the heart,
has
we give a
moderate
dose of
aortic
antegrade
regurgitation.
custodial
Okay.
very slowly.
Good.
Obviously, for
So what
patients
we're
with
going
aortic
to do
regurgitation,
is going to
the
deliver a dose of
custodial
antegrade
will be
cardioplegia. So
will
first
go
of all,
into the
to empty
ventricle
out the heart,
with each
empty out the
cardiac
aneurysm.
contraction.
Vent is
The
off.
custodial
Sucking on the
solution
root
will
vent.
be
So we can
perfused
see
into
the
the
ascending
coronary,
aorta is flat. Okay,
and the
give a
heart will
dose of
slow down
antegrade
downwards.
custodial
Just
down the
make sure you
root.
don't distend the heart,
Okay.
and then the pressure has to be low,
Control
and
the
the whole
pressure
process is
to about
relatively
80.
slow.
So what happens
Maintain
is
the
filling up
pressure down the
an
root about
aortic
80,
root, ascending aortic
and
aneurysm
then
with
once the
custodial
aneurysm is opened
cardioplegia.
up, you give direct
So with each heartbeat,
cardioplegia.
the coronaries are
So we'll be
perfused
able to arrest
by
all the heart without any problems,
the cardioplegia
even with
solution.
someone
So
with
that
severe
will
aortic
allow the heart
regurgitation.
to
So really avoid
slow
having all
down
the
on
lines
the
coming through the same
fibrillation
incision
and
and spending all the
each
time to do the retrograde. And the more holes you make, the more bleeding you will have at the end of the case. So really try to keep the whole operation simple. Now this is a very simple and very effective maneuver. That is to apply the traction sutures just above the commissures, really hitch up the commissure and to deliver the annulus almost to the level of the skin edge.
So now we have excised the aortic.
So you can see there are 3 traction sutures just above the commissures.
Placed 3 sutures, traction sutures above.
The bigger the aneurysm, once you remove the aneurysm, the more room you will have. The aorta generally in patients with a large aneurysm, the annulus is getting pushed down and also towards the left side, almost to the level of the xiphoid. So once the aneurysm is removed, you can actually effectively deliver the whole annulus almost to the level of the skin, and you really can enjoy the medial access surgery. Without fail, generally speaking, you can deliver the annulus almost to the level of the skin. But a 5 centimeter distance between the level of the skin to the annulus is quite comfortable to do an aortic root replacement. Now I use this French cuff technique, that is trying to fold the skirted portion of the Valsalva graft outside over the Valsalva portion of the graft, form a double cuff, and then put a tissue valve inside. The annular sutures first pass through the sewing ring of the tissue valve, and then through the everted cuff edge, and parachute the valve, and also contour down and tie down the annular sutures. So that is the first layer of annular anastomosis to anchor down the valve and also the graft. And then perform the second layer, which will take about an extra 20 minutes or 15 to 20 minutes. And that is using forward running Crowley suture, incorporating the remnant of the aortic wall and also the everted cuff edge to really try to make that anastomosis hemostatic. Because once the cross clamp is off, the annulus is going to be lost down there behind the sternum. So the hemostasis at this point is crucial, because you don't want that proximal anastomosis to leak. You don't want to even to worry about it once the cross clamp is off. Then the coronary buttons. Be careful with the right coronary button, especially if the right coronary button is vestigial relationship to the where you're going to put the graft on. And we published this technique a while ago. You can certainly do valve-sparing root replacement, David procedure, through a 5 centimeter incision. It's quite comfortable. I use a 3 millimeter ball tip to release the aortic root circumferentially. And the whole conduct of the operation is no different from open procedure. And as I said, the sternal division is always to the left side because you want to open up that junction between the aorta and the pulmonary artery. And the right side of sternal division has a little problem, sometimes especially around the right coronary annulus, because that area is tucked under the main sternal plate. So the left-sided sternal division is much more convenient. In terms of distal anastomosis, always use this double layer technique, using a first layer running protein suture, stitching towards you, and then perform a second layer anastomosis there and then to make sure the back wall is absolutely hemostatic. You do it now. Once the crossplane comes off, if the bleeds from the back wall will be difficult to fix. You can use interrupted sutures, the continuous protein sutures at the second layer, but I think it's more secure to do another layer anastomosis now. In terms of the arch surgery, well, for hemiarch, that's quite simple. My routine practice is moderate hypothermia with antegrade cerebral perfusion, unilateral, via an innominate with direct cannulation. You can do auxiliary if you like to, but I think it is very reproducible with this approach to perform a distal arch proximal arch anastomosis with the open distal technique. In terms of the arch surgery, the key is the management of the left subclavian artery and also distal aortic anastomosis, as Joe mentioned before. Proximalizing the distal anastomosis to zone 2 level will make the arch surgery very simple. But I use a branch first technique in this incidence, and also select the patients with distal arch aortic aneurysms because the epiaortic vessels will be presented to you. If you have patients with mid-arch and proximal arch aneurysms, the head and neck vessels actually pushed away, the access will be difficult. So upper hemistenotomy, central aortic cannulation. For patients with saccular aneurysm, you want to aim the cannula towards the root to avoid a sandblast effect. Debranch the innominate artery with a trifurcated graft and perfuse that vessel, and debranch the left common carotid artery, and then finally left subclavian artery. Now, if the subclavian artery is difficult to reach, or quality of the vessel is poor at the base, I just divide it with a vascular stapler and do the distal aortic anastomosis first with a frozen elephant trunk, and deal with the left subclavian artery during rewarming, either in the form of left subclavian carotid artery bypass or extra anatomical bypass, and then drop the graft into the left chest and bring out to the ascending aortic graft. Anything you can do to make it simple, to make the surgery safer. So, as I said, the key is management of the subclavian artery in these cases, and then select the right patient. Obviously, not all patients with arch aneurysm are suitable for this, but there are suitable cases you just have to look out for. Now, for a distal arch aneurysm, and my preference to use Thoraflex frozen elephant trunk to address this and exclude the saccular aneurysms, and through a small access incision. So overall, I think that will that's the axis. In this particular case, the patients had a 6 centimeter axis and with a frozen elephant trunk delivery. And operation, it's just by stages, and once you follow the steps, the performance of the procedure is actually quite smooth and straightforward. Well, here is our initial results for the first 150 cases with quite acceptable perioperative outcomes. Now we do run a minimally invasive cardiothoracic surgical course here in Sydney, based with a cadaver model. And thank you for your time and attention. We'll take some questions towards the end.
Thank you very, very much, Tristan. That was a very detailed, minimally invasive approach platform, and looking forward to discussions later on. You want to, Eric? You want to introduce our next,
sure.
the best, the most important speaker of the whole thing?
That's right. Yeah, Marco, you did a fantastic job of putting together a really clean program. And we're looking forward to hearing from you in this step-by-step technique session to explain to us your thoughts about evolving frozen elephant trunk surgery, normothermic, without circulatory arrest. We've seen, many of us have seen some of this and looking forward to this step-by-step presentation you're going to share with us. Thank you.
Thank you, Eric. Thank you, Joe. My cornerstone in total heart surgery, number one, antegrade selective cerebral perfusion is better than deep hypothermia and circulatory arrest for brain protection. Number two, axillary and innominate artery cannulation is better than femoral artery cannulation unless you don't have a shock patient with a type A dissection. For arch reconstruction, I do believe that the separate graft technique is a better technique than the island technique because it shortens the duration of visceral ischemia. And I think we all agree that the classic and the frozen elephant trunk represent a major advance, a major progress, allowing us to treat patients with extensive disease of the thoracic aorta. So thanks to this major understanding that we have generated over the last 20 years, results after this complex operation are good. We can perform complex frozen elephant trunk surgery in very complex patients with results that are good. But when we look at mortality and morbidity in details, we see that remain substantial, with mortality complication ranging between 5 and 11%. Why is that? Because I think that arch repair with frozen elephant trunk still maintain one important limitation, and that is hypothermia and circulatory arrest. The fact that we as surgeons are good with hypothermia and circulatory arrest does not make hypothermia and circulatory arrest good for our patient. And I think that probably without knowing, we're lying a little bit to ourselves or to vascular surgeon proposing a total endovascular solution for arch repair when we say, well, circulatory arrest is not a problem. Probably is not a problem for the surgeon, but it remains a little problem for the patient. This is not an opinion, this is an evidence that the duration of visceral ischemia is a risk factor for mortality and morbidity during aortic heart surgery and frozen elephant trunk surgery in particular. So I think that as a surgeon, we should do our best to minimize or possibly avoid the limitation. These are my institution, my university and my hospital. I moved here about 5 years ago. Time flies, and I was very lucky to realize that I had a very strong vascular surgery department and a very good and talented vascular surgeon to partner with, Emanuele Gatta. So we thought it was important to collaborate, and apparently also far beyond the operative theaters. We thought it was important to put together our experience, our skills, and with reference to frozen elephant trunk intervention to avoid hypothermia and circulatory arrest. And our journey started in these patients with proximal type 1 endoleak after TEVR, patients that are normally treated with circulatory arrest, total arch replacement, graft to endograft anastomosis with circulatory arrest. So we thought that by cannulating cranially the innominate artery and distally the femoral artery, and by using a balloon endoclamp at the level of the stent graft, we could perform our distal anastomosis, graft to endograft anastomosis, without 1 second of circulatory arrest, and probably normothermic, and that's what we did. You see here, the balloon, we inflated the balloon, get aortic occlusion, cardioplegia was delivered, and we opened the aorta. We got a perfectly bloodless operative field. We resect the ascending aorta, the aortic arch, and you see the stent graft at the balloon. So we could perform our aortic arch reconstruction without 1 second of circulatory arrest. After the first case we did like this, we shifted to normothermic. So we thought after that, well, if we can first deploy our stent graft and then use the technique that we've been using for a type 1 proximal endoleak, then we can construct our frozen elephant trunk from the beginning and avoid hypothermic circulatory arrest. And this is the operation that we published on Tristan Young's journal. Innominate artery cannulation, femoral artery cannulation, we're placing some hemoclips here to mark our proximal landing zone. We are off pump. You see the C-arm, we get another femoral access. We navigating with our guide wires up to the aortic valve. And off pump, we deliver the stent graft that is advanced here now up to the, we intentionally cover the left subclavian artery. The stent graft is deployed. And after that, we want to simulate our balloon endoclamping. So we go up with the balloon catheter, we simulate, we define the perfect spot where we want to clamp the aorta, we define the volume we need for perfect aortic occlusion, we put a marker on the balloon catheter, the C-arm is removed, we start on the pump, we immediately revascularize with an 8 millimeter interposition graft the left subclavian artery, we start with a flow of 300 cc, we clamp the aorta, we give cardioplegia. While doing that, we cannulate selectively the left common carotid artery with Professor Di Bartolomeo's cannulas. Maybe he's watching us now. We gently clamp the innominate artery. So we clamp the stent graft, and this is what Paolo Beretta is doing right here now. So we can open the aorta, and again, we have a perfectly bloodless operative field, no catheters in the operative field. We see the stent graft, you see the balloon, which is perfectly occluding, and again, without circulatory arrest, well perfusing the lower body, normothermic, we could complete our aortic arch reconstruction. After the distal anastomosis has been performed, the balloon is deflated. This is de-airing. This is absolutely not necessary, but this is a reminiscence from standard surgery. We go to the proximal anastomosis to minimize the duration of myocardial ischemia. De-airing, the clamp is off, and we complete the reconstruction by sequential revascularization of the arch vessels, and this is the result. After dealing with our aortic aneurysm, we felt we were ready to deal with type A dissection. And we had one young patient, well perfused, good conditions, 140 kilos. He came to our hospital, and we thought we could do the same. And we added something new here, in particular, the use of a 24 French introducer that was used to advance and deploy the stent graft, to advance the catheter balloon, and also as a perfusion cannula. I think it was important part of the procedure that of, after the stent graft deployment, that of advancing the tip of the introducer into the stent graft in order to have an antegrade blood perfusion of the dissected thoracoabdominal aorta after the stent graft was clamped with a balloon. This is the patient. He had an arch tear at the level, he had a tear at the level of the arch. This is a short clip showing the procedure. Guide wires. We catheterize the true lumen. We are on the pump. We deliberately covering the left carotid and left subclavian in this patient. The introducer is going up. This is the stent graft deployment. You see the introducer is advanced to have the tip inside the stent graft. So the balloon catheter is advanced into the stent graft, so is the arterial cannula. That is connected to the arterial line. We perfusing the patient from the innominate artery now, but what we're doing here is to inflate the balloon, open the arterial femoral line. This is what I'm doing here, and then get antegrade perfusion of the dissected thoracoabdominal aorta from the introducer that is placed into the stent graft. And again, we open the aorta and we get, we see the stent graft that we just deployed. I think this was the first total arch replacement where we froze the elephant trunk without a second of circulatory arrest. And the patient did extremely well, extremely well. We've done 13 patients so far. We lost one patient. This was a lady with 75 years old, severe COPD with ventilatory therapy, obese, unfit for endovascular repair. She did very fine over the at the beginning of the first 2 days, but then she had a respiratory failure. She was reintubated, and that was the beginning of the end for this lady, unfortunately. But if you forget the patient, we had almost zero complications, zero major complications. So we're very satisfied about it. I go to and this is important. This is important. This is the mean peak lactate value from our first 13 patients. 1.1 millimole liters. This is normal value, showing that we are perfectly perfusing our patient. This is something very important to us. So the key messages. The fact we're good with deep hypothermia and circulatory arrest does not make deep hypothermia and circulatory arrest good for our patient. I think it is important that the cardiac surgeons and industries work hard to develop techniques and technologies that may avoid hypothermia and circulatory arrest. I believe this could be a very important step forward. Catheter-based techniques during aortic heart surgery may help us offering better intervention. So I believe it is important the cardiac surgeon begin to think different and with humility, if necessary, learn from zero how to use wires and catheters. It is much easier than you can imagine. We started the TAVI program, a mitral Trans-Catheter program. That can be done, absolutely. And last message is this one. Multidisciplinary collaboration is important. It's important to learn, to grow, and to evolve. And collaboration with our vascular surgeon and cardiologist is certainly the best. And I've been very lucky to find Manuel as a partner in my aortic team. But if you don't find the right partner, well, that should not stop you and your catheter-based program in cardiac surgery. Thank you very much.
Thank you very much, Marco. That was outstanding and very innovative.
Great.
So our next, we'll have discussion at the end. We have a number of questions from that were relayed to us from the audience, and we will get to those. But our last discussion, our last presentation, is by Dr. Agostinelli from Parma, Italy. He's going to give us a video.
Dr.
Hello,
everybody. Yes, I'm here. Can you hear me?
Yes.
Can you hear me? Yeah, great. I would like to say hello to everyone, and thanks to the organization and to Marco for giving me this opportunity. It's a great honor and privilege for me to speak on such an important meeting in front of such an important audience. Today, I'll give a talk about a case of a combined transapical valve-in-valve TAVI and a ascending aorta TEVAR and a complex redo case. The case is about 64. We can start the video. The case regards a 64 years old male who was referred to a Spoke Hospital for congestive heart failure, and he was submitted in 2009 to aortic valve replacement with a stentless valve, 25 stentless valve, and ascending aorta replacement for the Becky type 2 acute aortic dissection. He was a very fragile patient with multiple comorbidities, among which peripheral artery disease and coronary artery disease and myasthenia gravis and previous stroke. So the echocardiographic, the transesophageal echocardiography showed aortic valve regurgitation due to structural deterioration of the valve, and the CT scan showed a pseudoaneurysm of the distal anastomotic side of the vascular graft previously implanted. As I said, he was a very sick patient with very fragile, and so we decided to submit the patient to a combined transcatheter transapical procedure. We used a Gore aortic cuff 45 millimeters for the ascending aorta TEVAR, and we used a Sapien Ultra 26 valve for the TAVI procedure. And both the procedure were used placing through a 21 Edwards certitude sheath inserting into the left ventricular apex. We performed the procedure in the cardiac surgical operating theater with a portable C-arm intensifier and under echo guidance. We decided to go for a surgical cut down of the femoral vessels just in case of potential surgical bailout, just because it was such a complex procedure. The left ventricular apex was isolated in a standard manner through a left anterior anterolateral mini thoracotomy in the 5th or 6th intercostal space. And we, as usual, we performed the finger test just to locate the exact spot where to enter into the left ventricle. You said the left ventricle was punched with the finger with the use of the 4 chambers view. So we put 2 perpendicular 2 0 polypropylene stitches reinforced with Teflon felt just to gain a perfect hemostasis after removal of the sheet itself. Here you can see the preoperative angiography showing the pseudoaneurysm is not clearly seen, but it was quite far from the origin of the brachiocephalic trunk. Here we tested the sheath and we saw if the aortic cuff passed through the certitude sheath, and after that we placed the sheath into the left ventricular apex. As you can see, we chose a very short aortic cuff to place in a stride portion of the ascending aorta, and with the neck of the pseudoaneurysm 3 centimeters far from the origin of the brachiocephalic trunk, and as I said before, in a stride portion of the ascending aorta, and with the proximal landing zone into the previously implanted Dacron graft. After that, we removed the pigtail and we delivered the prosthesis under ventricular pacing just to obtain great stability and to gain more accuracy in the graft deployment. You can see here the deployment of the stem graft. After that, in a standard manner, we implanted the Sapien Ultra 26 valve. We usually use 2-step procedures. We partially inflate the balloon and then check with angiography the correct position and make the slight correction to achieve the perfect position. And then we move on fully deploying the valve and fully inflating the balloon. After that, you can see it's coming next, the echocardiographic control showing a correct positioning of the valve. This is the long axis view. You will see in a moment no paravalvular leak, there's just a small central leak that is confirmed in the short axis view just due to the presence of the wire that is still left in place in case of postoperative aortic valve post-dilatation. That was not required in this case. So after that, the guide wire was removed. This is the postoperative angiography showing the correct positioning of the stent graft. No seal effect, no Burbeck effect, and no endoleaks. The postoperative course was uneventful. The patient has a 1-day ICU stay, and he was discharged on 6th postoperative day with an echocardiography pre-discharge showing correct functioning of the prosthesis, of the aortic prosthesis on a mean gradient of 11 millimeter of mercury. And at the CT scan, pre-discharge CT scan, as you can see, in a moment, you can see the correct positioning of the valve, the exclusion of the pseudoaneurysm, and the absence of endoleak. The patient we just made a follow-up control last week. Is doing well, and the CT scan 6 months confirmed the results. Thank you very much.
Thank you very much. Thank you so much. Well, I think we're going to go to the questions first, and then we'll go to the discussion. Eric, you want to tee up the next question?
Sure. Let's bring that ballot up. So we'll see if we've got any change in our results from before and after our presentations. So please try and answer these questions again. Surgery of the thoracic aorta will most likely progress through the development of A, minimally invasive surgical approaches, B, hybrid techniques, that is a combination of open and catheter-based techniques, C, totally endovascular approaches, or D, continuous refinements of the current open surgical techniques. Please take a minute to answer this question again.
This will be a very interesting question. It's a good question. Okay, so ballot's closed. Let's go to the second question now. So the second question for the ballot is, what is your favorite approach for aortic arch repair? Open, total aortic repair with classic elephant trunk, a hybrid 1, which is the total aortic repair with frozen elephant trunk, or hybrid 2, which is a debranching procedure of some sort with a TVAR solution, or total endovascular arches. All right. I suppose we can, let's wait. Should we have the discussion first before we give the, let's start the discussion first,
Sure.
Eric, okay?
Yeah,
and
that sounds good. That sounds good, Joe.
we'll do the ballot at the very end, just to kind of figure it out. So listen, I have a question for you, Eric. This one comes from, hi guys, everybody out there. That's good to see. So the first question is for Eric, which is, what's the future for endovascular treatment of the ascending aorta? How much of a role will it play in the future?
Well, I think that, as we've seen all these different tools displayed in this really nice group of presentations today, one thing that's different about aortic disease than, for example, isolated aortic valve stenosis is the heterogeneity of patients and pathologies that we see. So I think it's going to play an increasing role for us. And where I think it's going to be really important is going to be just like the last case we saw is in patients with focal disease, like a pseudoaneurysm of the ascending aorta. When we have a device that we can deliver in a really accurate way, that will probably be a really sound way to take care of that problem, because we can trust a stent graft in a good landing zone like a graft. The other role, which I think we're going to see grow and expand as we gain more experience and we have better devices, is in treating acute type A or really both the Bakey 1 and 2 aortic dissections. Initially, it'll expand our options for these people that are sort of in that prohibitive category or very high risk category. But as we become better with it, we may actually even see it expand into other patients who have good anatomy, where we can seal off that proximal entry tear as kind of a bridge. Because, so many of these patients that present with a type A dissection have a really complex postoperative course, not so much because of what we do to them, but because of the combination of insults of the acute disease that they're undergoing, and then they undergo a big surgery. So if we can seal off a primary entry tear and even get them through the hyperacute phase and come back later on and do some kind of elective reconstruction, we may learn that is another role as we become more comfortable with this going down the road.
Marco, you have a
Joe,
comment?
I got a comment. I got a question, not a comment for Eric.
Okay.
We also thinking about approaching patients with type A dissection with endovascular solution for patients that are deemed as inoperable, let's say. What is your suggestion? How would you do it? Retrograde or transapical? Because I see advantages from both sides. What is your opinion?
Oh, I think retrograde from the femoral artery is the way to go. The nice thing about transapical is you're draining a pericardial effusion. But if you can go transfemoral and do a subxiphoid window to deal with the effusion, it's going to be less of a burden on that patient. You might find that apex is friable and it's difficult to deal with.
Okay.
Yeah, I would say having been in the ARISE trial as well, that we'll be doing this with the ascending aorta graft. But the key here is having a graft that is tailored to the ascending aorta. It's very difficult right now to do this without a good graft. So that's the key, I think, is the design of the graft. And frankly, the ARISE graft, or the ascending graft, is actually really incredibly good. So this is a question for me from the audience. Do you think endovascular treatment will become the gold standard treatment for arch repair? and what are the main limitations? And I would say that yes, it will eventually become a major part of aortic arch repair. Absolutely, it's going to increase its dominance on a year-to-year basis. However, the problem right now is that it's a little bit complicated in dissections. It's has too many kind of alternate problems like type 1A endoleaks. It has a high stroke rate, especially in atherosclerotic aneurysms. So it's actually not quite ready yet for ubiquitous use. It is being used a lot where there's a proximal setup, so to speak, as Eric said, where you have a graft in the ascending aorta and then a well-placed graft, and then could do an arch endograft. But I do believe it is actually going to go forward. There was also a question about frozen elephant trunk versus the zone 2 TVAR. What do you prefer? And I already said that I tend to prefer zone 2 with delayed sequential TVAR in most cases, unless there's a primary reason to do the frozen elephant trunk first. So I think both of them are going to be very complementary. Any comments on those questions from the audience by anybody? Nope. Okay.
I think what you said is accurate, Joe. But we'll probably see better frozen elephant trunk technologies, expand our options as well. And so, we'll see a lot of different various uses from various surgical teams. What do you think, Marco?
I agree. Marco, yeah.
Trunk indications are expanding, and there are still some limitations. As I said during my talk, spinal cord injury, we can reduce it by doing the anastomosis at a more proximal cranial level for sure. We're doing that without circulatory arrest. I think it's a good point for us.
Okay, well, there's a couple of questions.
We've got some questions for you, Roberto. One of the questions I thought was really relevant was about what are the elements of an aortic team that you think are critical to have in place to handle all these newer technologies, especially in light of what's happening with thoraco-abdominal aneurysm repair.
But I think that the future will be completely a team formed by cardiac and vascular surgeons. I think that this is very important, and I recognize this situation in my department. Professor De Usanio knows very well my situation, and I think that a fusion between the two philosophies and the two techniques is very, very appropriate for the surgery of the future. I think that today is not possible to do arch without knowing very well the endo technique, and it's necessary at the same moment to know very well the open surgery technique, because I think in my personal opinion, a fusion of the two is the best possibility that we offer.
We're done with these questions. Roberto, what about the role? What about the role of cardiology? Have you developed some cardio aortic specialists on the medical side as part of your team?
In my team exists a specific cardiologist dedicated to the aorta. Is a cardiology that comes from UTIC, and is a cardiology that completely dedicated to the aorta. I think that also this new figure is otherwise important, because also the medical part is very important, and also anesthetist dedicated to the aorta. I think that cardiology, but first anesthetist dedicated to the aorta. Very important for me.
Right. Joe, should we
make a comment?
Yeah, go ahead, make a comment, please.
Yeah, I think the key concept that I learned from this meeting and then learning my career, that you know, in medicine, especially in oncology, it's coming up the concept of personalized medicine based on the specific response of each patient to a certain kind of drug. So I think we have to move to the same concept of surgery. We have to perform a really tailored approach to the patient, and this pass only through the acquisition of multiple competencies and through the multidisciplinary team building. I think that the focus of this meeting is very important. It's a key point, and because without having competences on the left ventricular apex of on the vascular skills, I couldn't have treated that patient. So I thank Marco because I think this is a very important concept for the future of our discipline. Thank you.
I completely agree. Why don't we, Eric, you want to go to the questions and get them done?
Sure. Let's see the results.
And then we can comment on them because they're actually the two most important concepts, I think. Okay, so surgery of the. Go ahead. You do the first one, Eric, since that was your question.
Well, I think it's pretty clear that both before and after that our audience of probably many surgeons who appreciate where things are going selected hybrid techniques as the primary treatment option. But after the presentation, it looks like that extended even further, and I guess there'll continue to be some role for some minimally invasive approaches and total endovascular approaches. I don't know why continuous refinement went away. I'm sure that'll be happening in concert with all these other things.
Yeah, I think this question, keep the question up if you don't mind. No, keep the other question up, please. So go back. I think yes, thank you. I think the key thing here is what's been discussed regarding the idea that we have to have a multidisciplinary team. I do believe that the hybrid techniques, which is really, the kind of the multiple domains of open surgery with catheter-based or TEVAR technology is really going to dominate. And it's probably because it's best for our patients in the long run and in the short term as well. So it's really interesting that the one area that kind of came out positive was the hybrid techniques as far as it's moving the audience, so to speak. I find that interesting. Okay, and I thought that would be the case too, although I thought total endovascular approaches would do better. Okay, so the next one is, and I'll wait for Eric to give me a discussion on this one. Vote for your favorite approach for aortic arch repair. It looks like hybrid 1, which is the frozen elephant trunk technique, actually did the best, and actually took a little bit more of the audience after the presentations. As you can see, went from 52 to 57% with the frozen elephant trunk techniques. Also, total endovascular took a little bit of an increase as well. So I suppose that was probable. What do you think, guys? How do you think the audience answered that question? What was going through their minds? Marco, Tristan?
When I look at the presentation, I think I'm with reference to the last question of the ballot. When I think about the presentation from Eric, from your presentation, and also from Professor Chiesa's presentation, I see that endovascular took 80% of your time. So I see that the endovascular is growing, and it will certainly be, the great part of our reconstruction, for sure. That's why we have to learn that, and I'm wondering if it will be really possible to collaborate with the vascular surgeons, really, because I'm very lucky. Professor Chiesa said, and I know that very well, that he has a very good collaboration with the cardiac surgeon, but this is not always like this. This is in the vast majority of cases there is big competition between the two groups, while it should not be like that.
Marco,
certainly
can
in our
I
institution.
reflect? Marco,
Sorry,
I agree.
Go ahead. Professor Chiesa. Go ahead first, and then we'll get Tristan.
I agree generally with you, Marco. In my opinion, today is not 80% endo and 20% open. For thoracic abdominal, for thoracic abdominal aorta is 50-50 today. I don't know if I have a very happy, a very good situation, but it's not an active competition between cardiac and vascular. For example, you do frozen elephant trunk together. You do the supraortic trunk, and the cardiac surgeon do the ascending the aorta, and you put the endoprothesis. For example, for acute cases like type A, non-type A, non-type B dissection, you do together this, for example. So I think that is depend from our to join a situation that is more useful for everybody. I think we depend from our teaching, but our capacity to do to introduce the new technique for everybody, cardiac and vascular surgeon. This is my idea.
Tristan, thank you very much, Professor Chiesa. Tristan Yan, Dr. Yan, would you like to comment?
No, I was just going to make a comment on the ballot results, that I think that it certainly reflects the current trend where we have a hybrid approach, and also just not surprised with arch intervention, we're more moving towards to open surgical technique with a frozen elephant trunk, a hybrid approach as well. I think that the answers reflect the current practice. The point where was Mark, you mentioned about the competition between vascular and cardiac surgeons. We're very fortunate in our institutions. We have a strong collaboration with our vascular colleagues, and that's the key. And that is, we all work together at MDT setting, multidisciplinary setting, and work towards the best outcome for our patients. Even though the open repair still is quite a mainstay treatment for arch surgery, but we more and more see maybe 30-40% of our patients also being considered for a hybrid approach.
But the big thing is regarding the arch TEVAR is that presently most of the successful arch operations, TEVAR operations, which we do a lot of, are really anchored in a proximal open operation. I mean, that is really critical at this point. It just seems that the ascending aorta is a little bit of a hostile territory for a landing zone in many cases. So the collaboration between the two is really, really important, not only for kind of management of patients, but actually just thinking about how to proceed with kind of total thoracic aortic replacement and reconstruction. I think we're on a dawn of a new era between vascular and cardiac, frankly. I'll give the last word to Dr. Eric Rosselli before we take the chairman's prerogative of completing this session, which is already 30 minutes late. Dr. Rosselli.
Thanks, Joe. Thanks, Marco. Thanks to all of our speakers for a great session. I would just like to echo the comment that was made about precision medicine. I think, the one thing that we're seeing is as our tool for treating aortic disease become more varied, the responsibility is on us to understand exactly how they can complement each other, all of these different techniques, so that we can really tailor them to our patients. And hopefully the next time we give a talk about what aortic surgery will look like in 2040, we'll talk about some of the medical therapies to help preventing any of these mechanical treatments that we have. Thanks for the opportunity to talk about disease that requires all of our attention, and look forward to seeing you all in person sometime soon. Thanks, Joe.
Yes, and thank you, Marco, for organizing this. And again, hopefully we'll see each other in Ancona in the future. Great job, Marco.
Ciao.
I think it was just a great day. I really enjoyed both sessions, the mini cabbage and the aortic. I knew that the naming contemplated my faculty was just fantastic, but and I think the results are also saying a lot. We had more than 2,300 devices connected today, so it was much more than I could expect. So thank you for being with us. Tomorrow is another day, and tomorrow we will have 2 sessions that will be focusing on minimal invasive and Trans-Catheter techniques for mitral valve repair. Big faculty again tomorrow, so I really hope that you will join us for the final day. Thank you very much and see you tomorrow. Bye-bye.